Hey guys, tonight we're talking about a drug that turns human flesh into rotting meat while users are still alive. Xylazine was designed to calm 1,000-pound horses before surgery, but it's now eating people from the inside out on American streets. The drug causes wounds so severe that doctors compare them to flesh-eating bacterial infections, except there's no bacteria involved, just chemistry gone catastrophically wrong. Users call it Trank, and it's mixed into nearly every bag of heroin and fentanyl sold in major East Coast cities. The paradox is darkly beautiful. Veterinarians created this compound to reduce animal suffering during medical procedures, and it's now become one of the most horrifying additions to America's drug supply. People inject what they think is heroin, then watch their skin turn black and peel away like overcooked meat falling off a bone. Emergency rooms see patients with holes in their legs so deep that bone is visible, and the necrosis often appears nowhere near the injection site. Arms rot when they inject into legs. Legs rot when they inject into arms. The drug doesn't care about logic. Dear viewers, our big goal is to reach 1,000 subscribers on this channel, and with your support, we can achieve it. Only on our channel will you find such interesting and unique stories about drugs. Subscribe so you don't miss them. We are sincerely grateful to everyone who helps us achieve this goal. Also, write in the comments where you're watching from and what time it is. I'm always curious to see people from all over the world brought together by a single story. And now, let's move on to today's story. To understand how a veterinary sedative became a zombie drug, you first need to understand the mundane origins of pharmaceutical research in 1960s West Germany. Bayer, the same company that gave the world aspirin and accidentally marketed heroin as cough medicine for children, employed a chemist named Dr. Helmut Zeugner at their Wuppertal laboratories. Zeugner wasn't trying to create the next street drug. His team was researching antihypertensive compounds, medications to lower dangerously high blood pressure in humans. The work was methodical and boring, involving endless variations of chemical structures and testing on laboratory animals. In 1962, Zeugner synthesized a compound designated as BAYV-A1470, which would later receive the generic name Xylazine. The molecule belonged to a class called alpha-2 adrenergic agonists, a term that means absolutely nothing to normal people, but everything to the story that follows. Xylazine's mechanism is elegantly destructive. Imagine your nervous system as a busy restaurant kitchen during dinner rush. Signals flying everywhere, commands being shouted, controlled chaos producing the result of keeping you alive and conscious. Xylazine walks into that kitchen and unplugs everything. It binds to alpha-2 receptors in the brain and spinal cord, which normally regulate the release of norepinephrine, the chemical that keeps you alert, maintains blood pressure, and generally prevents you from collapsing into unconsciousness. When Xylazine locks onto these receptors, it tells the body to stop releasing norepinephrine. Blood pressure plummets, heart rate drops, consciousness fades. The restaurant kitchen goes dark and silent. The early tests on laboratory rats showed profound sedation within minutes. Mice curled into balls and stopped moving for hours. Larger animals like dogs and rabbits became completely immobile, yet their eyes remained open. A disturbing combination that suggested the drug wasn't simply putting them to sleep, but rather disconnecting their voluntary muscle control while leaving some awareness intact. Bayer researchers noticed something else. The compound was wildly effective at muscle relaxation, far more so than other sedatives available at the time. A tranquilized animal wouldn't just become drowsy, it would become a limp-breathing statue. Human testing told a different story. Clinical trials in the mid-1960s revealed that Xylazine produced unacceptable side effects in people. Blood pressure didn't just drop, it crashed to dangerous levels. sometimes causing subjects to faint or experience cardiac complications. The sedation was too profound and lasted too long. Subjects reported disturbing experiences, being aware but unable to move, feeling disconnected from their bodies, experiencing severe anxiety as the drug wore off. Some developed bradycardia so severe their hearts beat fewer than 40 times per minute. The compound failed every reasonable standard for human medication. Bayer quietly shelved xylazine for human use and shifted focus entirely to veterinary applications. This is where the drug found its true calling, at least initially. Large animals present unique challenges in veterinary medicine. You cannot simply ask a 1,500-pound bull to hold still during an examination. Horses panic during procedures and can injure themselves and veterinarians with devastating kicks. Wild animals captured for research or conservation work require sedation that's both powerful and predictable. Xylazine solved these problems beautifully. A horse given an intramuscular injection of xylazine would become docile within 5 to 10 minutes, standing quietly with its head lowered while veterinarians performed minor surgeries, dental work, or examinations. The drug's long duration, sedation lasting 1 to 2 hours, meant procedures could be completed without additional dosing. The United States Food and Drug Administration approved xylazine for veterinary use in 1972 under the brand name Rompun. The approval was limited strictly to animals, with particular emphasis on horses, cattle, and deer. Veterinarians embraced the drug immediately. Compared to older sedatives that required precise dosing or carried higher risks of complications, xylazine offered a wide margin of safety in animals. A horse could tolerate significant variation in dose without experiencing respiratory failure or cardiac arrest. The drug became standard equipment in equine medicine, wildlife management, and agricultural veterinary practice. Bottles of Rompun sat on shelves in rural veterinary clinics across America, unremarkable and uncontroversial. The chemical structure of xylazine tells you why it works so differently across species. The molecule is relatively simple, a thiazine ring. Picture a hexagon with a sulfur atom and a nitrogen atom replacing 2 carbon atoms, attached to smaller chemical groups that determine how it interacts with receptors. In horses and cattle, xylazine binds tightly to alpha-2 receptors, but causes manageable decreases in cardiovascular function, because these animals have different receptor distributions and cardiovascular systems adapted to their massive body sizes. Their blood pressure can drop significantly without triggering the catastrophic effect seen in smaller primates. The drug was never meant for bodies built like humans. Regulations surrounding xylazine remained relatively loose because nobody imagined humans would deliberately inject a horse tranquilizer. The compound wasn't classified as a controlled substance. Veterinarians could order it freely from pharmaceutical suppliers. Agricultural workers used it on farms without extensive tracking or documentation. The assumption was simple. Why would anyone abuse a drug that made them unconscious and offered no euphoria or pleasurable effects? This assumption would prove catastrophically wrong, but that revelation was still decades away. Through the 1970s and 1980s, xylazine maintained its quiet existence as a veterinary tool, known only to animal doctors and large animal handlers. The drug did occasionally appear in unusual contexts. Some reports emerged of xylazine being used by criminals to sedate guard dogs during burglaries. Wildlife poachers used it to tranquilize animals before killing them. These uses were illegal, but represented such a tiny fraction of the drug's distribution that they barely registered as concerns. The DEA tracked xylazine loosely, but saw no pattern of human abuse or diversion into illicit drug markets. Toxicology reports from overdose deaths in the 1980s and early 1990s showed no presence of xylazine. The drug remained invisible to the addiction medicine community and law enforcement agencies focused on the crack cocaine epidemic ravaging American cities. What nobody anticipated was the fundamental economics of drug dealing. When you're cutting heroin or cocaine to increase profits, you need substances that add weight and bulk while ideally contributing some effect that makes customers return. Inert cutting agents like lactose or mannitol dilute the product but offer nothing to the user. Smart dealers prefer adulterants that enhance or prolong the high, creating a competitive advantage. During the 1990s, most heroin was cut with quinine, which added bitter taste users associated with quality, or with other sedatives like benzodiazepines, which enhanced the relaxing effects. But these additives were expensive or controlled substances themselves, eating into profit margins or creating additional legal risks. Xylazine solved multiple problems simultaneously, though this realization emerged slowly and initially far from the American mainland. The drug was cheap. Veterinary suppliers sold it at prices far lower than pharmaceutical-grade drugs meant for humans. It was unregulated and legal to purchase for anyone with a plausible veterinary reason, and enforcement of even those minimal restrictions was essentially non-existent. Most crucially, xylazine produced sedation that dramatically prolonged and intensified the effects of heroin. A dose of heroin that might keep someone high for 3 to 4 hours could last 8 hours or longer when mixed with xylazine. For dealers, this meant customers needed to buy less frequently, but the trade-off was that customers developed fierce loyalty to suppliers who carried the enhanced product. The first documented cases of xylazine appearing in human drug supplies emerged from an unexpected location, Puerto Rico, around the year 2000. The island occupied a unique position in drug trafficking routes between South America and the continental United States. Heroin flowing from Colombia often passed through Puerto Rico, where local distribution networks added their own modifications. Someone, history hasn't preserved exactly who, had the idea to cut heroin with xylazine purchased from agricultural suppliers serving the island's horse racing industry and cattle ranches. The mixture produced effects that users initially found appealing: deeper sedation, longer duration, a heavier body sensation. They called it anesthesia de caballo in Spanish, literally horse anesthesia. Emergency room physicians in San Juan began seeing strange cases in 2001 and 2002. Overdose patients presented with symptoms that didn't match typical heroin or cocaine intoxication. The sedation was too profound and lasted far too long. Standard naloxone treatment, which reverses opioid overdoses by blocking opioid receptors, worked only partially. It would wake patients enough to breathe but left them deeply sedated for hours afterward. Blood pressure readings were alarmingly low, sometimes 70/40 or worse. Heart rates dropped into the 40s. Most disturbing were the skin problems. Users developed wounds that wouldn't heal, surrounded by tissue that looked grey and lifeless. The wounds appeared randomly, sometimes near injection sites, but often on completely different parts of the body. Doctor Carmen Albizu Garcia, a researcher at the University of Puerto Rico, began investigating after hearing reports from harm reduction workers and emergency departments. Her team conducted urine tests on patients presenting with these unusual symptoms and discovered xylazine metabolites in their systems. Further investigation revealed that xylazine was being added to as much as 40% of Puerto Rico's heroin supply by 2003. The adulterant wasn't appearing randomly or accidentally. It was a deliberate strategy by multiple trafficking organizations operating on the island. Albizu Garcia published papers documenting the phenomenon, but her warnings reached limited audiences. Addiction medicine journals paid attention, but the assumption was that this was a localized Puerto Rican problem, confined by geography and unlikely to spread to the mainland. That assumption, like the assumption that nobody would abuse a horse tranquilizer, was spectacularly wrong. The drug was already moving north through trafficking networks that connected Puerto Rico to Philadelphia, New York, and other East Coast cities. By 2005, Xylazine was appearing in drug samples seized by law enforcement in Pennsylvania, though quantities were small and detection sporadic. Nobody yet understood that they were witnessing the early stages of a new phase in America's opioid epidemic. The zombie drug was coming, and the bodies weren't ready. For 3 decades, Xylazine lived a double life that nobody recognized as contradictory. In veterinary clinics from Montana to Maine, the drug remained an essential tool for keeping animals calm during procedures that would otherwise be impossible. A dairy cow needing hoof trimming received an injection and stood placidly while farmers worked on legs that could kick with bone-breaking force. Wildlife biologists darted elk with xylazine-loaded syringes, allowing them to fit tracking collars on animals that would normally flee or attack. The drug was so routine that veterinary students learned to calculate dosages based on animal weight as part of their basic training, using simple formulas: 0.5 to 1.0 milligrams per kilogram for horses, slightly higher for cattle, adjusted based on the procedure's invasiveness. Zoo veterinarians relied on xylazine for managing everything from routine health checks to emergency interventions. A Bengal tiger requiring dental work couldn't be asked to open its mouth voluntarily. Xylazine provided the deep sedation necessary to examine 3-inch canine teeth without risk of the animal waking mid-procedure and mauling the veterinary team. Zookeepers mixed the drug with other sedatives to create cocktails specific to different species. Bears required different protocols than big cats, which differed again from primates. The combinations were refined through decades of trial and error, documented in veterinary journals with titles like Effective Chemical Restraint of Captive Asiatic Black Bears using xylazine-ketamine combination. Agricultural applications made xylazine indispensable to industrial farming operations. Cattle operations used the drug when branding calves, castrating bulls, or performing minor surgeries in the field. Traveling veterinarians carried bottles of Rompan in their trucks, alongside antibiotics and basic surgical equipment. The drug's stability at room temperature meant it didn't require refrigeration like many other veterinary medications. A rancher could keep a bottle in the barn for months without degradation, pulling it out whenever an animal needed emergency treatment. This convenience contributed to widespread distribution across rural America, with xylazine present on thousands of farms where horses or cattle were raised. Equestrian sports created massive demand for xylazine as horse racing and show jumping grew into billion-dollar industries. Racehorses required regular veterinary attention, joint injections, dental work, treatment for injuries sustained during training or competition. Xylazine allowed veterinarians to perform these procedures quickly without general anesthesia, which carried higher risks and required expensive equipment. Show horses underwent frequent cosmetic and medical procedures to maintain their competitive value. The drug became so associated with horse medicine that many equestrian professionals referred to it simply as xylazine, without needing brand names, the way people say aspirin instead of acetylsalicylic acid. Research institutions used xylazine extensively in laboratory animal studies. University medical schools conducting experiments on large animal models, pigs, sheep, dogs, required sedation protocols that were both effective and reversible. Xylazine fit these requirements perfectly and appeared in thousands of scientific papers as a standard methodology component. Researchers studying cardiovascular function, surgical techniques, or disease progression all utilize the drug to keep experimental animals immobilized during procedures. The compound's presence in academic research was so ubiquitous that it became invisible, mentioned in method sections but rarely discussed in detail because everyone in the field understood its properties and uses. human medicine never forgot about xylazine entirely, though the interest remained purely academic. Pharmacology textbooks included the drug in chapters about alpha-2 adrenergic agonists, usually in comparison to drugs like clonidine or dexmedetomidine that were approved for human use. Medical students learned that xylazine was the veterinary equivalent of these human medications, but with far more dramatic effects and unacceptable side effects in people. Research papers occasionally explored why the drug works so differently across species, investigating receptor subtypes and metabolic pathways. These studies confirmed what clinical trials had shown decades earlier. Xylazine produced excessive bradycardia, dangerous hypertension, and prolonged sedation in humans and primates. The cardiovascular effects made xylazine uniquely unsuitable for human medicine. When blood pressure drops by 20 or 30% in a 1,500-pound horse, the animal's massive circulatory system compensates without difficulty. The same proportional decrease in a 150-pound human creates immediate medical crisis. Blood flow to the brain becomes insufficient, causing syncope, sudden loss of consciousness. Coronary arteries receive inadequate pressure, potentially triggering cardiac ischemia in anyone with underlying heart disease. The heart's electrical system can destabilize, leading to arrhythmias that range from inconvenient to fatal. These effects weren't mysterious or unpredictable. They were exactly what you'd expect from a drug designed for animals with completely different physiology. Respiratory depression added another layer of danger. Xylazine doesn't shut down breathing as dramatically as opioids, but it significantly reduces respiratory rate and depth. A horse sedated with xylazine might drop from 16 breaths per minute to 8, which is perfectly safe for an animal that size. A human experiencing the same proportional reduction might go from 12 breaths per minute to 4 or 5, barely enough to maintain adequate oxygen levels. The combination of the low blood pressure and reduced respiration creates a deadly synergy. Less blood reaching the tissues, and what little blood is flowing carries insufficient oxygen. Cells throughout the body begin suffering hypoxic damage within minutes. We hope you have already subscribed to our channel, and if not, please do so right now. Our goal is to reach our first 1,000 subscribers. This is very important to us. Only on our channel will you find such interesting and unique stories about drugs. Subscribe so you don't miss them, and we'll get back to the story. The drug's metabolic pathway in humans remained poorly understood because so few studies had been conducted. What researchers knew came primarily from accidental exposures in veterinarians and agricultural workers. Case reports described people accidentally injecting themselves while handling syringes or getting splashed with xylazine solution during animal procedures. These accidental exposures caused immediate symptoms: dizziness, profound drowsiness, slurred speech, inability to stand. The effects lasted 6 to 12 hours, far longer than the sedation produced by most drugs acting on the central nervous system. Victims described the experience as nightmarish, being aware but unable to move, feeling disconnected from their bodies, experiencing intense anxiety that they couldn't express because their muscles wouldn't respond to mental commands. Veterinary safety protocols address these risks through strict handling procedures and required protective equipment. Veterinarians learn to draw xylazine into syringes carefully, always pointing the needle away from their bodies. Clinics maintain supplies of atipamezole, a specific antidote that reverses xylazine's effects by blocking alpha-2 receptors. The antidote worked quickly in animals, restoring consciousness and normal cardiovascular function within 15 to 30 minutes. This reversal capability made xylazine even more attractive for veterinary use. If complications arose during a procedure, the veterinarian could simply inject atipamezole and bring the animal back to alertness. The same antidote worked in humans. though few hospitals stocked it since human xylazine exposure was considered an extremely rare occupational hazard. Control measures surrounding xylazine remained minimal throughout its history as a purely veterinary drug. The compound required no special DEA registration to purchase or prescribe. Veterinary supply companies sold it to anyone with a professional account, which essentially meant anyone who claimed to work with animals. Online suppliers offered bottles of xylazine with minimal verification of purchaser credentials. The regulatory assumption was that market forces and professional ethics would prevent misuse. Only people who genuinely needed animal sedatives would buy them, and those people had legitimate uses. This assumption ignored the basic economics of black markets. Where there's demand, supply routes will emerge regardless of regulatory intent. Mexico's role in xylazine distribution began innocuously through legitimate veterinary pharmaceutical manufacturing. Mexican companies produced generic xylazine for the country's substantial agricultural sector. Cattle ranching, horse breeding, and dairy farming all created steady demand. The manufacturing standards were lower than in the United States or Europe, but the product worked adequately for its intended purposes. Some Mexican veterinarians prescribed xylazine more liberally than their American counterparts, using it not just for procedures, but as a mild sedative for anxious animals or to manage chronic pain in livestock. This looser prescribing culture meant larger quantities of the drug circulated through agricultural communities, particularly in northern Mexican states. Chinese pharmaceutical manufacturers entered the xylazine market in the late 1990s as part of a broader expansion into veterinary drug production. Chinese factories could produce the drug at costs far below Western manufacturers by utilizing cheaper labor and less stringent environmental regulations. The quality varied wildly. Some Chinese xylazine was pharmaceutical grade and indistinguishable from Bayer's original product, while other batches contained impurities or incorrect concentrations. By 2000, Chinese-manufactured xylazine dominated the global veterinary market outside of North America and Europe. The same factories that produced legitimate veterinary supplies also operated parallel production lines for the black market, manufacturing drugs without proper documentation and shipping them through channels designed to avoid customs scrutiny. The first hint that xylazine might become a drug abuse problem appeared in Puerto Rico's surveillance data between 2000 and 2002, but the warning signs were subtle and easily dismissed. Toxicology reports from overdose deaths occasionally showed xylazine presence, but always in combination with heroin or cocaine, making it unclear whether the xylazine contributed to death or was merely an incidental finding. Users who survived overdoses rarely mentioned xylazine specifically when describing what they'd taken. They just knew the heroin felt stronger or lasted longer. Harm reduction organizations conducting drug checking services detected xylazine in some samples, but lacked the resources to investigate further or track trends systematically. Law enforcement agencies missed the pattern entirely. Police officers seizing drugs in Puerto Rico dutifully logged the weight and tested for standard substances, heroin, cocaine, marijuana, methamphetamine, but rarely performed comprehensive analysis that would detect xylazine. The compound wasn't on their radar because it wasn't a controlled substance and had never been associated with drug abuse. Even when xylazine appeared in laboratory tests of seized drugs, investigators often assumed it was a contaminant or byproduct of synthesis rather than a deliberate adulterant. The machinery of drug enforcement was designed to detect known threats, and xylazine didn't fit any existing category. By 2005, between 15 and 30% of Puerto Rico's heroin supply contained xylazine, depending on the region and supply network. Users developed preferences for dealers who sold the good stuff, heroin cut with xylazine that produced longer-lasting and more intense effects. Some dealers began advertising their products specifically as containing anesthesia, using the presence of xylazine as a selling point rather than trying to hide it. The market had spoken. Despite the veterinary origins and despite the unusual side effects, users wanted xylazine adulterated heroin because it delivered more value for their money. Addiction doesn't care about pharmaceutical appropriateness. The wounds were already appearing, though nobody yet connected them to xylazine specifically. Emergency departments in San Juan, Ponce, and other Puerto Rican cities treated increasing numbers of injection drug users with ulcerated necrotic tissue around injection sites. Doctors attributed these wounds to typical complications of injection drug use: bacterial infections, contaminated needles, poor injection technique, or adulterants like quinine that were known to cause tissue irritation. The wounds looked worse than typical abscesses, but the patients were injecting drugs. Of course, they had severe medical complications. The medical establishment's existing biases about drug users prevented careful investigation into whether something new and different was happening. Researchers who studied the Puerto Rico phenomenon published warnings in journals like Substance Abuse and the Journal of Addiction Medicine. Dr. Albizu Garcia's team documented xylazine's presence in drug supplies and correlated it with unusual clinical presentations. These papers were methodologically sound and raised genuine concerns, but they reached limited audiences. Most addiction medicine specialists practiced in mainland United States and viewed Puerto Rico as a separate epidemiological environment with unique factors that wouldn't necessarily translate to their own populations. Island geography, different trafficking routes, distinct cultural patterns around drug use. All these factors made it easy to dismiss Puerto Rican findings as interesting, but not relevant to American cities. What nobody realized was that trafficking networks don't respect geographic or cultural boundaries. The same organizations moving heroin from Colombia through Puerto Rico to the United States were taking notes on what worked. Xylazine was cheap, legal to acquire, and made the product more competitive. By 2006, small quantities of xylazine adulterated heroin were appearing in Philadelphia, though in amounts too small to trigger widespread notice. The bridgehead was established. The zombie drug had reached the mainland, and the catastrophe was beginning. Puerto Rico's position as the first battleground for xylazine wasn't accidental, but rather the inevitable result of geography, economics, and opportunity converging in a 3,000 square mile laboratory. The island sits directly in the Caribbean trafficking corridor that funnels South American cocaine and heroin toward the American mainland. Colombian drug organizations used Puerto Rico as a transshipment point because the island's status as a U.S. territory meant goods moving from Puerto Rico to Florida or New York faced less stringent customs inspection than international shipments. Drug interdiction focused on boats and planes arriving from South America, not domestic cargo flights departing San Juan for Miami. Local distribution networks on the island operated with relative sophistication compared to street-level dealers in many American cities. Puerto Rican trafficking organizations maintained relationships with Colombian suppliers while also managing their own processing and cutting operations. These groups didn't just pass drugs through, they added value by cutting, packaging, and branding products before shipping them onward. Heroin arriving from Colombia in relatively pure form would be cut to appropriate street-level concentrations, typically reducing purity from 70 or 80% down to 30 or 40%. The question was always what to cut it with. Traditional cutting agents like lactose or mannitol were cheap but offered nothing to distinguish one dealer's product from another. Quinine had been the gold standard for decades because its bitter taste mimicked the taste of pure heroin, allowing dealers to pass off heavily cut product as higher quality. But quinine was expensive and increasingly difficult to source as pharmaceutical regulations tightened. dealers who wanted competitive advantages needed adulterants that actually enhanced the high, rather than merely disguising dilution. Someone in Puerto Rico's trafficking networks, exact identity lost to history, remembered the horse tranquilizer readily available from the island's agricultural suppliers. The island's horse racing industry provided perfect cover for bulk xylazine purchases. Hippodromo Camarero in Canovanas had operated since 1976 as Puerto Rico's premier racing facility. Hundreds of horses required regular veterinary care, making large orders of sedatives completely unremarkable. Veterinary supply companies servicing the racing industry stocked bottles and vials of xylazine in various concentrations. A purchase order for 50 or 100 vials raised no suspicions because legitimate veterinary operations regularly ordered those quantities. The same supply chains served the island's cattle ranches, dairy farms, and private horse owners scattered across the mountainous interior. Early experiments with xylazine cutting happened between 2000 and 2001 in the working-class neighborhoods of San Juan and Carolina. Dealers purchased veterinary-grade xylazine, the liquid formulation at 100 milligrams per milliliter, or dry powder, and mixed it with heroin at ratios that required trial and error. Too little xylazine produced no noticeable enhancement. Too much knocked users unconscious for dangerously long periods. The optimal ratio emerged through marketplace feedback. Users who liked the product returned and told their friends, while users who had bad experiences complained or switched dealers. Economic Darwinism refined the formula to roughly 1 part xylazine to 20 parts heroin by weight. The effects were immediately distinctive. Users accustomed to heroin's 4-hour window of euphoria and sedation found themselves high for 8 or 10 hours after injecting xylazine-laced product. The sedation was deeper, heavier, more physically immobilizing than heroin alone. Users described feeling like they were sinking into the ground, or made of lead. The euphoria was less intense but lasted significantly longer, and the transition from high to sober was more gradual rather than heroin's relatively sharp come-down. For people whose lives revolved around acquiring and using drugs, this extended duration meant fewer trips to dealers, less money spent, and more time actually being high rather than desperately seeking the next fix. Street names proliferated across Puerto Rican drug markets. Anesthesia de Caballo was too long for regular use, so it shortened to simply anesthesia. Some dealers called it Sleeping Beauty in English, marketing to younger users who spoke both languages. Others used tranquilo or calmante, tranquil or calming, emphasizing the sedative properties. The variety of names initially obscured the fact that all these products contain the same adulterant. Users requesting anesthesia from one dealer might not realize that tranquilo from another dealer was chemically identical. This naming confusion delayed public health officials' understanding of how widespread xylazine use had become. Medical complications manifested almost immediately, though the pattern only became clear in retrospect. In 2001, emergency departments across Puerto Rico logged increasing numbers of overdose cases that responded incompletely to naloxone treatment. Standard protocol for opioid overdoses involved administering Narcan, which should restore consciousness and breathing within 2 to 5 minutes. Instead, emergency physicians found patients whose breathing improved, but who remained profoundly sedated, sometimes for 6 to 12 hours. Blood pressure readings stayed dangerously low despite IV fluids and supportive care. Hospital admission rates for overdoses increased because patients couldn't be safely discharged while still deeply unconscious. The wounds started appearing in 2002, initially dismissed as unrelated to the drug supply. Injection drug users frequently developed abscesses, cellulitis, and skin infections from non-sterile injection practices. These complications were so common that emergency physicians barely registered them as noteworthy. But the xylazine wounds looked different. They were larger, progressing faster, and surrounded by tissue that appeared greyish and devitalized rather than the red, inflamed appearance of typical bacterial infections. The ulcers often developed not at injection sites but on distant areas of the body. Someone who injected into their arm might develop necrosis on their leg or torso. Hospital wound care teams in San Juan began seeing cases that resembled necrotizing fasciitis, the infamous flesh-eating bacterial infection. Surgeons debrided dead tissue expecting to find streptococcal or staphylococcal bacteria, but cultures came back negative or showed only opportunistic organisms rather than the aggressive pathogens that cause necrotizing fasciitis. The wounds behaved strangely. Antibiotics had minimal effect. Tissue death continued to spread despite surgical intervention, and healing was extraordinarily slow even with proper medical care. Some patients required skin grafts for wounds that started as small ulcers but expanded to expose underlying muscle and bone. Doctor. Carmen Albizu Garcia's research team at the University of Puerto Rico's Behavioral Health Center began investigating systematically in 2002 after hearing consistent reports from harm reduction workers. The team collected urine samples from 50 patients presenting with overdose symptoms or unusual wounds and sent them for comprehensive toxicology analysis. 42 of the 50 samples tested positive for xylazine metabolites in addition to heroin and cocaine. This wasn't contamination or coincidence, it was a pattern. The researchers expanded their sampling to include users who hadn't overdosed or developed wounds, collecting specimens from needle exchange sites and outreach programs. Xylazine appeared in 35 to 40% of samples from active drug users, depending on location and social network. The team's findings, published in 2003, documented what was essentially Puerto Rico's uncontrolled human experiment with veterinary sedatives. The paper described clinical presentations, documented the presence of xylazine in overdose cases, and warned that the adulterant was becoming entrenched in the island's drug supply. Albizu Garcia's group interviewed users who confirmed they specifically sought out xylazine-containing heroin because of its superior duration and intensity. One interviewed user, whose words appeared anonymized in the research paper, explained that regular heroin felt weak after experiencing xylazine-enhanced product. The veterinary sedative wasn't just contaminating the supply, it was becoming a desired component. Distribution networks formalized xylazine sourcing as demand increased. By 2003, trafficking organizations weren't relying on small-scale purchases from veterinary clinics, but rather importing xylazine in bulk from Mexican and Chinese manufacturers. Wholesale prices were absurdly low. 1 kilogram of xylazine powder cost roughly $200, while the same weight of heroin cost $50,000 or more. The profit mathematics were compelling. A dealer who cut 1 kilogram of pure heroin with 19 kilograms of lactose and xylazine could produce 20 kilograms of street-level product. The xylazine added less than $10 per kilogram to production costs while making the product significantly more competitive. Geographic patterns emerged showing xylazine concentration in specific municipalities. Bayamon, a city in the San Juan metropolitan area, showed xylazine presence in more than 50% of drug samples collected by law enforcement. Ponce, Puerto Rico's second-largest city on the southern coast, had similarly high contamination rates. Rural areas initially showed lower percentages, but this appeared to reflect different supply chains rather than genuine absence. As testing became more comprehensive, xylazine appeared throughout the island, from the beaches of Rincon to the mountains of Jayuya. No region was spared. Law enforcement responses remained completely inadequate throughout this period. Puerto Rico Police Department drug units continued prioritizing traditional metrics: weight of drugs seized, number of arrests made, disruption of trafficking organizations. Xylazine didn't factor into these priorities because it wasn't a controlled substance. Officers who seized heroin and found it adulterated with xylazine had no additional charges to file. Cutting heroin with legal substances wasn't itself a crime. The legal framework was designed for a simpler era when drug adulterants were either other controlled substances or inert fillers. Nobody had anticipated that legal compounds could be deliberately weaponized to enhance illegal drugs. Health department interventions came slowly and achieved limited impact. Puerto Rico's Department of Health issued warnings to healthcare providers about xylazine in 2003, advising emergency departments to consider the possibility when treating unusual overdoses. The guidance recommended prolonged observation periods and aggressive supportive care but offered no specific treatment protocols. Hospitals were advised to stock atipamezole, the xylazine antidote used in veterinary medicine, but many facilities didn't follow this recommendation due to cost and the drug's lack of FDA approval for human use. The few hospitals that did stock atipamezole found it effective at reversing sedation, but less useful for treating the catastrophic wounds. Harm reduction organizations working directly with drug users provided the most practical response. Puerto Rico's needle exchange programs began distributing information cards warning about xylazine, describing symptoms of xylazine overdose, and recommending wound care protocols. Some programs trained peer educators, people in recovery or actively using who could communicate with current users more effectively than healthcare professionals. These peer educators spread information through drug-using social networks. Xylazine makes you nod harder, but the overdose risk is real. Watch your friends because Narcan only works part way. If you see weird wounds developing, get medical help immediately. The cultural context complicated public health messaging. Puerto Rico's drug-using population included people from all social classes, but the visible street-level users were predominantly from economically marginalized communities. Spanish-language communication was essential but often inadequate because drug slang didn't translate cleanly. More fundamentally, decades of drug war policies had created deep distrust between users and authorities. Government health warnings were often dismissed as exaggeration or propaganda, leaving harm reduction workers as the only credible messengers. By 2005, xylazine was thoroughly embedded in Puerto Rico's drug supply chain. Dealers who didn't cut their heroin with xylazine found themselves losing customers to competitors who did. The market had reached a tipping point where xylazine-free heroin was considered inferior product. Users actively asked dealers whether their supply contained anesthesia, and a negative answer meant lost sales. This market dynamic ensured xylazine's persistence regardless of public health interventions or law enforcement efforts. The drug served economic functions that made it nearly impossible to dislodge through conventional means. Trafficking organizations preparing shipments for mainland United States began including xylazine in those exports. If xylazine made heroin more competitive in Puerto Rico, the same logic applied to markets in Philadelphia, New York, and Boston. The initial exports mixed xylazine directly into heroin during cutting operations in Puerto Rico, creating a standardized product that arrived on the mainland pre-adulterated. Later refinements saw xylazine shipped separately, allowing mainland dealers to control their own cutting ratios and adjust to local market preferences. By 2006, the drug that had devastated Puerto Rico was landing in American cities, carried through networks that spanned from South American coca fields through Caribbean islands to urban streets 3,000 miles north. The contagion had escaped containment. Philadelphia became xylazine's American stronghold, not through random chance, but through the intersection of poverty, existing opioid infrastructure, and trafficking networks that had long connected Puerto Rico to Pennsylvania's largest city. The Puerto Rican diaspora in Philadelphia numbered over 130,000 by 2010, concentrated in neighborhoods like Fair Hill and Hunting Park in North Philadelphia. These communities maintained strong cultural and familial ties to the island, including commercial relationships that facilitated legitimate trade and provided cover for drug trafficking. When Xylazine adulterated heroin began arriving from Puerto Rico around 2006, it entered through established channels that had been moving narcotics for decades. Kensington Avenue became the geographic center of Philadelphia's Xylazine crisis, though the drug's reach eventually extended far beyond this single neighborhood. The area had been economically devastated since the 1980s collapse of manufacturing industries that once employed tens of thousands of workers. By 2010, Kensington featured blocks of abandoned factories, empty storefronts, and houses stripped for copper and left to rot. This landscape of abandonment created perfect conditions for open-air drug markets where dealers and users conducted business with minimal interference. Heroin dominated these markets, serving a user population that included both local residents and suburban buyers who drove into the neighborhood specifically to purchase drugs. The first Xylazine detections in Philadelphia appeared in drug evidence seized during 2006 and 2007, but quantities were minimal, trace amounts that toxicologists noted in lab reports without much concern. By 2008, those trace amounts had increased to significant percentages. Drug Enforcement Administration analysis of heroin samples from Kensington showed xylazine present in approximately 15% of specimens. A year later, that figure jumped to 30%. The progression was exponential rather than linear, suggesting rapid adoption by multiple trafficking organizations simultaneously, rather than gradual spread from a single source. Street-level economics drove the adoption pattern. Philadelphia's heroin market was intensely competitive, with dozens of trafficking organizations operating in overlapping territories. Product differentiation was essential for maintaining customer bases and market share. Dealers branded their heroin with stamps, small logos printed on glassine bags that served as both trademark and quality indicator. Names like Obama, Blue Magic, or Ferrari identified specific suppliers, and users developed brand loyalty based on perceived quality and effect. Xylazine offered a chemical advantage that no branding could match. It made heroin objectively stronger and longer lasting. The nickname Trank Dope emerged from street users sometime around 2009, though its exact origin remained undocumented. Trank was shorter and more phonetically distinctive than xylazine, and dope was standard Philadelphia slang for heroin. The name spread rapidly through user communities, appearing in conversations at needle exchanges and in emergency department records, where medical staff recorded patients' descriptions of what they'd used. By 2010, users asking dealers for Trank would receive knowing nods. Everyone understood what was being requested. The drug had achieved cultural recognition as a distinct category separate from plain heroin. Medical consequences manifested more dramatically in Philadelphia than they had in Puerto Rico, possibly because the concentrations were higher or because American healthcare surveillance systems caught the pattern more quickly. Temple University Hospital's emergency department, located near Kensington, began seeing unprecedented numbers of injection drug users with catastrophic wounds in 2010 and 2011. The wounds defied standard medical categorization. Too extensive for simple abscesses, too chronic for acute bacterial infections, too necrotic for typical injection complications. Tissue simply died and sloughed away, leaving ulcers that could span entire limbs. Dr. Joseph D'Orazio, an addiction medicine specialist at Temple, recognized that something new was happening when he saw 5 patients in a single week with identical wound patterns. All 5 had injected heroin purchased in Kensington. All 5 developed grey, devitalized tissue surrounded by intact skin, not the spreading erythema typical of infections. All 5 tested positive for xylazine in addition to opioids. D'Orazio contacted colleagues at other Philadelphia hospitals and discovered they were seeing similar cases. The wounds were appearing not just in Temple's urban emergency department, but also in suburban hospitals treating patients who admitted travelling to Philadelphia to buy drugs. The scale of tissue destruction exceeded anything in the medical literature on injection drug use complications. Patients presented with wounds ranging from small ulcers to massive defects exposing bone and tendons. A 28-year-old woman developed necrosis on her thigh, so severe that surgeons debrided tissue down to the femur, requiring multiple operations and ultimately a skin graft taken from her back. A 40-year-old man who injected into his forearm watched the skin on his lower leg turn black over 3 days. He'd never injected anywhere near his leg, but xylazine doesn't care about anatomical logic. These weren't marginal cases occurring once a month. They were daily presentations overwhelming hospital resources. Wound care specialists found themselves practicing improvised medicine because established protocols didn't work. Standard abscess treatment involves incision, drainage, and antibiotics. Procedures that assume bacterial infection is the primary problem. Xylazine wounds weren't primarily infectious. They were ischemic, caused by blood vessels constricting so severely that tissue died from oxygen deprivation. Antibiotics did nothing for ischemia. Surgical debridement removed dead tissue but didn't prevent continued necrosis because the underlying vascular problem persisted as long as xylazine remained in the user's system. The drug's long half-life meant tissue damage could continue for days after the last injection. Amputation rates among injection drug users in Philadelphia increased dramatically between 2010 and 2015. Temple University Hospital performed more than 30 amputations on patients with xylazine-related necrosis during 2012 alone. Most involved digits, fingers and toes destroyed by tissue death, but several required above-ankle or below-knee amputations when leg wounds extended too deeply for salvage. Each amputation represented a catastrophic failure. The drug war had failed to prevent xylazine's spread, harm reduction efforts had failed to reach the user in time, and medicine had failed to save the limb despite aggressive treatment. The human toll accumulated with bureaucratic efficiency in surgical logs and patient records. The psychological impact on users was uniquely horrifying because xylazine wounds developed while people remained conscious and aware. Opioid addiction numbs emotional pain but does nothing for the existential dread of watching your body decompose. Users saw their skin turn colours that skin should never be. Grey, purple, black. They smelled the distinctive odour of necrotic tissue, which resembles decaying meat because that's exactly what it is. They felt the strange sensation of dead flesh being cut away during debridement procedures, sometimes performed without adequate anesthesia because drug tolerance made pain management difficult. And yet they continued using because xylazine withdrawal produced anxiety so severe that the immediate psychological relief of using trumped future physical consequences. Harm reduction organizations in Philadelphia mobilized faster than government agencies, though their resources were desperately insufficient for the scale of crisis. Prevention point. Philadelphia, the city's primary needle exchange program, began distributing wound care kits in 2011. Each kit contained sterile gauze, antibiotic ointment, medical tape, and instructions for basic wound hygiene. The organization trained staff to recognize early signs of xylazine necrosis, grey discoloration, pain disproportionate to visible injury, tissue that felt boggy or waterlogged. Outreach workers approached users on Kensington Avenue with both supplies and information, offering concrete help rather than lectures about quitting. The Mobile Wound Care Initiative, launched in 2013, brought nursing care directly to drug users who would never visit hospitals until their conditions became emergencies. Nurse practitioners set up treatment stations in tents on Kensington Avenue, examining wounds, cleaning and dressing them, and referring the most serious cases for hospital admission. This approach acknowledged the reality that many users wouldn't seek care through traditional channels due to shame, fear of legal consequences, or simple lack of resources. Meeting people where they were, literally on the streets where they used drugs, proved more effective than waiting for them to appear in emergency departments with life-threatening complications. Drug checking services provided by harm reduction groups confirmed Xylazine's ubiquity in Philadelphia's heroin supply. Users could bring samples for testing using spectrometry, and fentanyl test strips augmented with Xylazine detection methods. Testing results from 2014 showed Xylazine present in 60 to 70% of heroin samples collected in Kensington. By 2015, that figure exceeded 80%. The drug had transitioned from adulterant to standard ingredient. Finding heroin without Xylazine was harder than finding it with. This market saturation meant users had essentially no choice about Xylazine exposure if they wanted to buy heroin in Philadelphia. Law enforcement remained structurally incapable of addressing Xylazine despite growing awareness of the crisis. Philadelphia Police Department narcotics units could arrest dealers and seize drugs, but Xylazine's legal status meant its presence didn't enhance criminal charges. A dealer caught with 10 grams of heroin faced identical charges, whether that heroin contained Xylazine or not. Prosecutors couldn't argue for enhanced sentences based on adulterants that weren't themselves controlled substances. The legal system was designed to punish trafficking in scheduled drugs, and Xylazine sat outside that framework entirely. Arrests and prosecutions continued at high rates while Xylazine proliferated unchecked. Federal authorities slowly recognized Philadelphia's Xylazine crisis, though their response remained fragmented across multiple agencies with different mandates. The DA documented Xylazine's spread through forensic analysis of seized drugs and overdose toxicology. The Centers for Disease Control began tracking Xylazine-involved deaths separately from standard opioid fatalities. The FDA maintained its position that Xylazine was appropriate for veterinary use only, but lacked authority to restrict its manufacture or distribution through veterinary channels. Each agency operated within its bureaucratic lane, generating reports and recommendations while the bodies accumulated. Trafficking networks adapted to enforcement pressure with impressive agility. Early Xylazine shipments arrived pre-mixed in heroin from Puerto Rico, but by 2012 Philadelphia dealers increasingly received Xylazine as a separate product for local cutting operations. This shift reflected sophistication in supply chain management. Shipping Xylazine separately allowed dealers to customize ratios for local preferences and reduced risk by separating legal from illegal substances during transit. Xylazine powder or liquid could be shipped through legitimate freight channels with minimal law enforcement scrutiny, while heroin required more careful smuggling through established routes. The two streams converged only at the final distribution point. Mexican trafficking organizations entered Philadelphia's Xylazine market around 2013, bringing industrial-scale supply capacity. Mexican cartels had dominated heroin supply chains to East Coast cities for decades, and their suppliers in Sinaloa and Jalisco had ready access to Xylazine through veterinary pharmaceutical manufacturers. Mexican Xylazine was cheaper even than Chinese product because production costs in Mexico were lower and transportation was simpler. The cartel's entry transformed xylazine from a niche adulterant to a commodity chemical available in essentially unlimited quantities. Price competition drove costs so low that xylazine added virtually nothing to dealers' expenses. It was almost free weight. The economic incentives had become perfectly aligned for maximum harm. Xylazine cost almost nothing. Users preferred it to plain heroin. Dealers gained competitive advantage by including it, and the resulting addiction was so severe that customer retention reached near-perfect levels. Users hooked on tranq dope couldn't easily switch to regular heroin because the withdrawal symptoms were worse and the high was less satisfying. This created captive markets where trafficking organizations could maintain customer bases with minimal effort. Philadelphia had become a case study in how market forces, combined with inadequate regulation and public health response, could turn a veterinary drug into an epidemic that destroyed thousands of lives. The city's wound care clinics were overwhelmed, its morgues were filling with xylazine-positive corpses, and the drug was just beginning its expansion into the rest of America. The mechanism by which xylazine destroys human tissue operates through a cascade of biological failures that compound into catastrophe. Understanding this process requires stripping away medical jargon to reveal the brutal simplicity underneath. Xylazine tells blood vessels to close, tissue starved of oxygen dies, and the body's repair mechanisms fail to activate properly. The drug accomplishes in hours what normally takes days of complete arterial blockage, compressing the timeline of tissue death into a frighteningly rapid progression that leaves users watching their flesh rot in real time. Blood vessels operate under constant tension between constriction and dilation, regulated by the autonomic nervous system. Alpha-2 receptors on smooth muscle cells in vessel walls respond to chemical signals that control this balance. When xylazine binds to these receptors, it triggers maximum vasoconstriction. The vessels clamp down as tightly as biologically possible. Imagine trying to push water through a garden hose while someone stands on it with full body weight. That's the physics of blood flow under xylazine's influence. Capillaries that normally measure 7 to 10 micrometers in diameter constrict to near closure. Arterioles feeding tissue beds reduce their radius by 50% or more. The math of fluid dynamics says that halving a vessel's radius reduces flow by a factor of 16. Tissue exists in a perpetual state of controlled starvation, receiving just enough oxygen to survive but with minimal safety margin. Brain tissue dies after 4 minutes without oxygen. Heart muscle manages 6 to 8 minutes. Skin and muscle tolerate longer hypoxia but still require consistent perfusion to maintain cellular function. Normal blood flow delivers roughly 15 to 20 milliliters of oxygen per 100 grams of tissue per minute. When xylazine reduces perfusion by 80 or 90%, tissue receives perhaps 2 to 3 milliliters of oxygen per 100 grams per minute, barely enough for basic cellular respiration and completely insufficient for repair processes or defense against pathogens. The cellular response to hypoxia follows predictable stages that medical students learn as reversible injury versus irreversible injury. Early stages involve cells switching from aerobic to anaerobic metabolism, producing lactic acid and depleting ATP stores. Sodium-potassium pumps fail when ATP runs out, allowing sodium to flood into cells and potassium to leak out. Water follows sodium through osmosis, causing cellular swelling. If oxygen returns within hours, cells can recover. If hypoxia continues, membranes rupture and cells undergo necrosis. Chaotic death characterized by inflammation and tissue destruction. Xylazine keeps tissue in the irreversible injury zone for extended periods, because the drug's half-life in humans ranges from 8 to 12 hours. The distribution pattern of xylazine wounds makes no anatomical sense until you understand that the drug circulates systemically through the entire bloodstream. Users injecting into their arms introduce xylazine into the venous system, which carries it to the heart and then out through arteries to every part of the body. The drug concentrates in areas with high receptor density or particular vulnerability to ischemia. Extremities are especially vulnerable because they're distant from the heart and operate with less generous blood flow. The tips of fingers and toes, which already receive minimal perfusion, become death traps when xylazine further restricts blood supply. Wounds appear wherever the toxic combination of drug concentration, injection trauma, and pre-existing vascular compromise creates a perfect storm. Research teams at Temple University documented the pathology through biopsy studies conducted between 2015 and 2018. Tissue samples from xylazine wounds showed massive endothelial damage. The single-cell lining of blood vessels was destroyed, leaving vessels leaky and non-functional. Fibrin deposits clogged capillaries, creating microscopic clots that prevented blood flow even after xylazine concentrations decreased. Inflammatory cells infiltrated dying tissue, but the inflammation was disorganized and counterproductive, destroying more tissue than it protected. The microscope revealed landscapes of cellular apocalypse, necrotic muscle fibers separated from their blood supply, fat cells ruptured and releasing their contents, connective tissue dissolved by enzymes leaked from dying cells. The synergy between xylazine and fentanyl transforms both drugs into something more dangerous than either alone. Fentanyl causes respiratory depression by suppressing the brainstem's breathing centers. Users simply forget to breathe or breathe too shallowly to maintain adequate oxygen levels. Xylazine adds cardiovascular collapse through severe hypertension and bradycardia. The combination creates dual threats. Fentanyl prevents oxygen from entering the blood, while xylazine prevents blood from reaching tissue. A user overdosing on this combination faces simultaneous respiratory and circulatory failure, explaining why naloxone administration often proves insufficient. Reversing the opioid restores breathing but does nothing for the blood pressure problem or the tissue ischemia. The immunosuppressive properties of xylazine doom wound healing before it can begin. Successful tissue repair requires coordinated action from neutrophils, macrophages, fibroblasts, and endothelial cells working to clear debris, fight infection, and build new tissue. Xylazine disrupts this coordination by suppressing immune cell function and preventing angiogenesis, the formation of new blood vessels that's essential for healing. Wounds remain open for months or years because the biological machinery needed for closure simply doesn't activate. Bacteria colonize these chronic wounds not as primary causes, but as opportunistic invaders taking advantage of immunocompromised tissue. Staphylococcus aureus and Pseudomonas aeruginosa grow enthusiastically in xylazine wounds, forming biofilms that resist antibiotic treatment. These secondary infections add another layer of tissue destruction on top of the primary ischemic damage. The classic signs of infection, heat, redness, swelling, pain, appear in strange patterns because the underlying tissue is already dead. Dead tissue can't mount inflammatory responses, so infections sometimes advance with minimal visible warning. A wound that looks stable can harbour massive bacterial populations beneath the surface, revealed only when surgeons debride and discover pockets of pus and liquefied tissue. The progression from early lesion to full necrosis happens with horrifying predictability once the cascade begins. Stage 1 appears as skin discoloration, a grey or purple hue that indicates poor perfusion. The area feels cooler than surrounding tissue because reduced blood flow means less heat delivery. Stage 2 involves blister formation, as the epidermis separates from the dying dermis beneath. These blisters contain sterile fluid initially, though they rapidly become infected if they rupture. Stage 3 reveals frank necrosis. Tissue turns black as hemoglobin breaks down, Skin becomes leathery and desiccated, and the distinctive smell of dead flesh becomes unmistakable. Stage 4 exposes deeper structures: fat, fascia, muscle, tendon, bone, as superficial layers slough away completely. Medical photography from Philadelphia wound clinics documented this progression with clinical detachment. Images showed wounds measured in centimeters initially, then expanding to encompass entire anatomical regions. A small ulcer on an ankle photograph expanded in subsequent photos to encircle the entire lower leg. Another series showed a forearm wound that started as a 2-centimeter lesion and progressed over 3 weeks to expose the radius bone along a 15-centimeter length. These weren't rare exceptional cases, but rather typical presentations of untreated xylazine necrosis. The disease process was predictable and inexorable without aggressive medical intervention. Surgical debridement became the primary treatment modality because no drug could reverse tissue that had already died. Surgeons used scalpels to cut away necrotic tissue until they reached viable, bleeding tissue that indicated adequate blood supply. The procedures were extensive. What appeared as a modest wound on the surface often extended deep into subcutaneous tissue and muscle. Debridement of a hand wound might remove tissue from palm to wrist, leaving a defect requiring grafting or flap reconstruction. The psychological trauma of watching surgeons carve away pieces of your body was compounded by the knowledge that continued drug use would cause the wounds to recur. Pain management in xylazine wound patients created cruel paradoxes. Opioid tolerance from chronic drug use meant standard analgesic doses provided inadequate relief. Patients required doses that would kill opioid-naive individuals just to achieve basic pain control. Prescribing these high doses risked enabling continued addiction, while underprescribing left patients in agony. Some wound care physicians refused to prescribe opioids at all to active users, arguing they would divert the medication. This forced patients to choose between untreated pain and street drugs that perpetuated the wounds. The medical system's inability to address addiction and acute pain simultaneously left many patients suffering needlessly. Advanced wound care protocols developed through trial and error as clinicians learned what worked. Negative pressure wound therapy, vacuum-assisted drainage systems that promote healing, showed some effectiveness in preparing wound beds for grafting. Hyperbaric oxygen therapy was attempted but showed limited benefit because xylazine actively prevents oxygen delivery, regardless of how much oxygen is in the blood. Biological dressings and growth factors aimed at stimulating angiogenesis failed because xylazine blocks the cellular machinery these treatments try to activate. The most successful approach combined aggressive debridement, long-term antibiotic coverage, and most importantly, complete abstinence from xylazine-containing drugs. Abstinence remained the impossible requirement. Xylazine withdrawal produces severe dysphoria, anxiety, and physical discomfort that drives users back to the drug despite visible bodily destruction. The withdrawal isn't as dramatically physical as heroin withdrawal with its vomiting and muscle cramps, but the psychological symptoms are arguably worse. Users describe feeling wrong or broken, a pervasive sense that something is missing from their neurotransmitter balance. This feeling persists for weeks after the last use, far longer than typical opioid withdrawal. Treatment programs lacked medications to address xylazine withdrawal, specifically because the drug had never been studied in that context. Research into potential antidotes and reversal agents produced limited results. Etipamezole, the alpha-2 antagonist that reverses xylazine in animals, showed promise in case reports of accidental human exposure. However, its use in chronic users was complicated by unknown interactions with long-term receptor changes and concerns about precipitating severe hypertensive crisis. The drug required intravenous administration and careful monitoring, making it impractical for field use. Some researchers proposed developing xylazine-specific naloxone-like medications that could be distributed to harm reduction programs, but pharmaceutical companies showed little interest in developing treatments for drug adulterants without clear profit potential. The financial burden of treating xylazine complications strained hospital systems already dealing with the opioid epidemic. Each patient with extensive wounds required weeks to months of hospitalization for serial debridements, antibiotic therapy, and wound care. Costs regularly exceeded $100,000 per patient, most of whom lacked private insurance and relied on Medicaid or charity care. Temple University Hospital alone spent millions annually treating xylazine wounds while receiving inadequate reimbursement for the complex, time-intensive care these patients required. The economics incentivized quick discharge rather than complete healing, ensuring that patients returned repeatedly for progressively worse complications. The biological science of xylazine necrosis was clear and comprehensively documented by 2018. But this understanding did nothing to slow the epidemic, because knowledge alone cannot overcome economics, addiction, and policy failure. Researchers could explain exactly how and why xylazine destroyed tissue, but they could not stop dealers from adding it to heroin or convince users to avoid it. The drug's mechanism of action had been decoded with academic precision, while the death toll mounted with mathematical inevitability, highlighting the gap between understanding a problem and solving it. Xylazine's geographic expansion from 2016 through 2021 followed trafficking routes with the precision of an invasion map, radiating outward from Philadelphia along established heroin distribution networks that connected major East Coast cities. Maryland documented its first significant xylazine detections in Baltimore during 2016, where the drug appeared in approximately 10% of heroin samples analyzed by the state crime laboratory. Within 18 months, that figure climbed to 30%. Baltimore's open-air drug markets in neighborhoods like East Oliver and McElderry Park began selling tranq dope using the same economic logic that had driven adoption in Philadelphia. The product lasted longer, users preferred it, and competitive pressure forced all dealers to either add xylazine or lose customers to rivals who did. Connecticut's crisis emerged with startling speed between 2017 and 2019. Hartford and New Haven had long established opioid problems, fed by trafficking organizations moving product up Interstate 95 from New York City. When those organizations began cutting their heroin with xylazine, Connecticut's users had no warning and no choice. The State Medical Examiner's Office recorded xylazine presence in 23 overdose deaths in 2017, then 81 in 2018, then 247 in 2019. This wasn't linear growth, but exponential explosion. Emergency departments across the state reported wound patterns identical to Philadelphia's experience: grey necrotic tissue, ulcers exposing bone, amputations becoming routine rather than exceptional. New York City's xylazine problem initially concentrated in the Bronx, where Puerto Rican trafficking connections remained strong and heroin use rates were among the city's highest. The drug appeared in Hunts Point and Fordham during 2017, then spread to Brooklyn's Brownsville and Bedford-Stuyvesant neighborhoods by 2018. Manhattan's Lower East Side saw xylazine-adulterated heroin arriving in 2019, though the problem remained less severe than in outer boroughs. New York's sheer size meant the crisis developed unevenly. Some neighborhoods experienced Philadelphia-level saturation, while others remained relatively unaffected based purely on which trafficking organization controlled local distribution. Massachusetts confronted xylazine later than its neighboring states, but with equal severity once the drug arrived. Boston's first documented xylazine deaths occurred in 2018, concentrated in areas like Mass and Cass. the intersection of Massachusetts Avenue and Melnia Cass Boulevard that had become the city's epicenter of visible drug use and homelessness. By 2020, state laboratory analysis showed xylazine in approximately 60% of heroin samples from the greater Boston area. Worcester, Springfield, and other Massachusetts cities experienced similar invasion. The drug supplies transformed within months as xylazine became standard rather than exceptional. The drug jumped geographic boundaries to appear in unexpected locations far from East Coast urban centers. Ohio recorded xylazine detections in Dayton and Cincinnati during 2018, initially puzzling law enforcement officials who assumed the drug was confined to coastal cities. The explanation emerged through DEA trafficking investigations. Mexican cartels supplying Midwestern heroin markets had begun adding xylazine at production facilities in Mexico, creating a standardized product shipped throughout their distribution networks. Ohio's users were injecting drugs that had traveled from Sinaloa through Texas and into the American heartland, pre-mixed with xylazine before ever crossing the border. West Virginia's opioid epidemic, already among America's worst, acquired a new dimension when xylazine appeared in Charleston and Huntington during 2019. The state's overdose death rate had exceeded 50 per 100,000 residents annually, more than double the national average, before xylazine arrived. Adding a tissue-destroying veterinary sedative to an already catastrophic situation pushed mortality and morbidity to levels that overwhelmed the state's limited healthcare infrastructure. Rural West Virginia hospitals lacked wound care specialists or the resources to treat extensive necrosis, forcing patients to travel hours to larger facilities or simply go without adequate care. Tennessee documented xylazine in Memphis and Nashville by 2020, while Kentucky found the drug in Louisville and Lexington the same year. The pattern was clear. Wherever heroin flowed, xylazine followed. No geographic barrier prevented spread once the drug entered national trafficking networks. The Appalachian region, already devastated by prescription opioid abuse and the subsequent switch to heroin, now faced a third wave driven by fentanyl and xylazine in combination. Communities that had buried hundreds of overdose victims were now also dealing with survivors whose bodies were rotting from drug-induced necrosis. The South experienced later but equally devastating xylazine invasion. North Carolina detected the drug in Charlotte and Greensboro in 2019. Georgia found it in Atlanta by 2020. Florida documented cases in Miami, Tampa, and Jacksonville throughout 2020 and 2021, though prevalence remained lower than in northeast states. The temporal lag suggested south to north trafficking routes operated somewhat independently from the Puerto Rico-Philadelphia axis that had dominated early spread. Mexican cartels were shipping xylazine-adulterated heroin directly to southern ports and border crossings, creating new fronts in the veterinary drugs' conquest of American drug supplies. California's experience with xylazine was initially mild compared to East Coast states, though this provided false comfort. Los Angeles County documented xylazine in approximately 5% of opioid overdose deaths during 2020, primarily in areas with established heroin markets rather than the fentanyl that dominated much of California's drug supply. San Francisco saw similar low-level contamination. The question wasn't whether xylazine would saturate western states, but merely when the economic incentives for dealers to adopt it would overcome regional differences in supply chains and user preferences. The COVID-19 pandemic paradoxically accelerated xylazine's spread by disrupting traditional drug trafficking patterns and forcing rapid adaptation. Border closures and travel restrictions throughout 2020 interrupted established smuggling routes, causing heroin shortages in many American cities. Dealers cut available supplies more heavily to stretch inventory, and xylazine provided an ideal cutting agent that maintained product potency despite reduced heroin concentrations. The pandemic also drove more drug transactions toward delivery services rather than open-air markets, and xylazine-enhanced heroin's longer duration made it attractive for users who wanted to minimize trips outside their homes during lockdowns. Supply chain analysis revealed the international logistics enabling xylazine's proliferation. Chinese pharmaceutical manufacturers in Hubei and Zhejiang provinces produced bulk xylazine powder for global veterinary markets, with annual production measured in tons. Some of this legitimate production was diverted to drug trafficking organizations through corrupt distributors or deliberately mislabeled shipments. Mexican cartels purchased xylazine from Chinese suppliers at prices around $100 per kilogram, then transported it to processing facilities in Sinaloa, Jalisco, and other cartel-controlled territories. The powder was mixed with heroin or fentanyl at ratios refined through user feedback and market testing, creating standardized products that could be distributed throughout North America. Dark web marketplaces facilitated xylazine distribution parallel to traditional trafficking channels. Vendors on sites like Alphabay and Dream Market offered xylazine powder in quantities from grams to kilograms, shipped internationally through regular mail services. These online sales targeted both small-scale dealers looking to cut their own products and individual users seeking pure xylazine for personal use. Cryptocurrency payments and encrypted communication allowed buyers and sellers to conduct transactions with reasonable confidence in avoiding law enforcement detection. The volume moving through dark web channels was tiny compared to cartel trafficking, but demonstrated how multiple distribution methods could coexist. Federal tracking efforts struggled to keep pace with xylazine's expansion. The DEA's National Forensic Laboratory Information System documented detections across states, but data collection lagged months behind real-time spread. State-level laboratories tested seized drugs and biological samples from overdose victims, generating statistics that confirmed xylazine's presence, but provided little actionable intelligence for preventing further expansion. The Centers for Disease Control tracked xylazine-involved deaths through death certificate data and medical examiner reports, publishing summaries that documented the crisis without offering solutions. Regional variation in xylazine prevalence created patchwork awareness among healthcare providers and first responders. Emergency physicians in Philadelphia and Baltimore knew to expect xylazine in virtually every heroin user, while doctors in Seattle or Denver rarely encountered the drug and might not recognize its effects. This knowledge gap had consequences. Patients traveling from high-prevalence areas to low-prevalence areas received inadequate care because local providers didn't understand what they were treating. Harm reduction organizations tried to fill this gap through online education and peer networks, but information spread far more slowly than the drug itself. State-level policy responses varied dramatically and often proved ineffective regardless of approach. Pennsylvania declared xylazine a public health crisis in 2019, dedicating funding to treatment and harm reduction, but achieving minimal impact on prevalence. Connecticut mandated reporting of xylazine-involved overdoses, generating data that documented the problem without preventing deaths. Ohio restricted xylazine sales by requiring veterinary prescription and DEA registration for bulk purchases, but these controls did nothing to stop illegal imports from Mexico and China. The mismatch between state-level policy tools and international drug trafficking realities meant most interventions were performative rather than substantive. The concept of the fourth wave of the opioid epidemic entered public health discourse by 2021, describing xylazine's transformation of an already catastrophic crisis. The first wave had been prescription opioids, the second heroin, the third fentanyl, and now the fourth combined fentanyl with xylazine and other novel additives. Each wave killed more people than the last and created new medical complications that healthcare systems struggled to address. The progression from pills to powder to synthetics to veterinary sedatives illustrated drug markets' continuous innovation in pursuit of profit, while public policy remained perpetually reactive. Toxicology data from 2020 and 2021 reveal the terrifying ubiquity Xylazine had achieved in some regions. Philadelphia Medical Examiner's Office found Xylazine in 91% of opioid overdose deaths during 2021. Virtually every fatal overdose involved the veterinary drug. Connecticut reported Xylazine presence in 67% of opioid deaths the same year. Maryland documented 53%. These weren't contamination or adulteration rates. They were the new normal baseline. Finding opioid overdose deaths without Xylazine was becoming the exceptional case rather than finding deaths with it. The demographic reach of Xylazine contradicted assumptions about drug epidemics affecting only marginalized populations. Suburban teenagers overdosing on what they thought was prescription oxycodone bought from classmates were dying with Xylazine in their systems because counterfeit pills pressed in clandestine labs contained fentanyl cut with Xylazine. Middle-aged professionals using cocaine recreationally developed necrotic wounds because their cocaine was cross-contaminated with Xylazine through shared cutting surfaces and packaging equipment. The drug spread through multiple substance categories meant essentially anyone using illicit drugs faced potential exposure. Construction workers in rural Pennsylvania developed rotting legs from tranq dope, used to manage chronic pain after workplace injuries. College students in Connecticut lost fingers to necrosis after experimenting with heroin during exam stress. Elderly patients in Baltimore suffered complications when they purchased street drugs to supplement inadequate pain management from physicians afraid of prescribing opioids. The individual stories accumulated into a collective portrait of American dysfunction, a society that had criminalized addiction, stigmatized users, and created economic conditions where animal tranquilizers became preferable to sobriety. By the end of 2021, Xylazine had been detected in 48 states, present in drug supplies from Miami to Minneapolis and Los Angeles to Boston. Only a handful of states, primarily in the Mountain West with smaller populations and different drug trafficking patterns, remained largely unaffected. But largely unaffected was a temporary status, not a permanent immunity. The drug was coming for everyone because the economic and addiction dynamics that drove its spread were universal. Xylazine had achieved what few drugs manage, becoming simultaneously a profitable business decision for traffickers and a sought-after commodity for users, creating a self-reinforcing cycle that no intervention had successfully disrupted. America's drug supply had been fundamentally transformed, and the zombie drug had won its war of geographic conquest. American emergency departments transformed into makeshift triage zones for a disease that medical school never taught and textbooks barely mentioned. Physicians accustomed to treating overdoses with naloxone protocols found themselves confronting patients who partially responded to treatment but remained comatose for 12 hours, their blood pressure hovering around 70/40 despite aggressive fluid resuscitation. The standard approach, administer Narcan, monitor for 2 hours, discharge if stable, failed completely with Xylazine because the veterinary sedative outlasted the opioid antagonist by 8 to 10 hours. Patients would wake briefly after naloxone injection, then sink back into profound sedation as the drug wore off, while Xylazine continued circulating through their systems. Hospital admission rates for opioid-related complications increased by 60 to 80% in high-prevalence areas between 2018 and 2022. Emergency departments designed to handle acute crises found themselves boarding patients for extended observation periods, because sending someone home while deeply sedated from xylazine meant almost certain death if they stopped breathing without medical intervention. Hallways filled with patients on gurneys waiting for inpatient beds that never became available because the wards were already full of other xylazine cases. The cascade effect overwhelmed healthcare systems operating at capacity even before the veterinary drug arrived. Wound care represented an even greater resource drain than overdose management. A typical abscess might require a 15-minute incision and drainage procedure in the emergency department, followed by outpatient antibiotic treatment. Xylazine wounds required serial debridements over weeks, each procedure taking an hour or more in the operating room with anesthesia and surgical staff. The hospital stay for extensive xylazine necrosis averaged 30 to 45 days, compared to 3 to 5 days for most surgical admissions. Each patient occupied a bed, consumed nursing hours, required pain management, received intravenous antibiotics, and generated costs that exceeded most hospitals' reimbursement rates from Medicaid or charity care programs. Temple University Hospital established a dedicated wound care clinic in 2016, specifically for xylazine-related injuries, becoming the first institution to acknowledge the crisis required specialized infrastructure. The clinic operated 3 days weekly, staffed by wound care nurses and a plastic surgeon who performed bedside debridements for cases too minor to justify operating room time. Even with this dedicated resource, appointment wait times stretched to 3 or 4 weeks by 2018. Patients with actively progressing necrosis had to choose between waiting for an appointment or visiting the emergency department for acute intervention, and most chose the emergency department, perpetuating the cycle of overwhelmed acute care services. The psychological dimension of watching your body decompose created mental health crises superimposed on the physical wounds. Patients developed severe depression and anxiety as they observed tissue turning black and dying, despite being fully conscious and aware. Some described the experience as being trapped in a horror movie where they were both victim and audience. The smell of necrotic tissue, sweet, rotten, unmistakable, followed patients everywhere, making them acutely self-conscious and socially isolated. Public spaces became impossible to navigate because the smell attracted stares and comments. Bus drivers refused to allow wound-bearing patients to board. Store employees asked them to leave. Suicide rates among xylazine users exceeded baseline addiction population rates by substantial margins, though comprehensive data remained elusive because many deaths were classified as overdoses rather than intentional self-harm. The distinction was often impossible to determine. Did someone inject a massive dose intending to die? Or were they simply trying to achieve the numbness that made daily existence tolerable? Psychiatrists treating wound patients reported that many expressed wishes for death or amputation, anything to end the physical and psychological agony. Yet these same patients continued using tranq dope because xylazine withdrawal created dysphoria so severe that even rotting alive seemed preferable to being sober. Pain management protocols disintegrated when confronting patients whose opioid tolerance meant morphine doses that would kill normal people provided barely adequate analgesia. Wound debridement involves cutting away dead tissue with scalpels, scraping down to viable bleeding tissue, and washing wounds with solutions that sting intensely. Performing these procedures on someone with years of heroin use required either general anesthesia or opioid doses that made prescribing physicians uncomfortable. Hospital pharmacists questioned orders for 200 milligrams of morphine every 4 hours, suspecting errors rather than understanding these doses were appropriate for the patient population. Some hospitals adopted policies refusing elective wound care for patients who continued active drug use, reasoning that treating wounds while users kept injecting xylazine was futile. This policy essentially sentenced patients to deterioration until their wounds became emergent, at which point they presented with exposed bone and systemic sepsis requiring amputation. The ethical calculation was brutal. Hospitals couldn't afford unlimited resources for patients who undermined their own treatment, yet abandoning them guaranteed worse outcomes and higher eventual costs. Neither choice was morally defensible, and physicians made decisions that haunted them regardless of what they chose. Specialized treatment programs emerged as traditional addiction services proved inadequate for Xylazine patients' needs. A program in Philadelphia called Prevention Point Wound Care Initiative provided field treatment directly on Kensington Avenue, bringing nursing care to users rather than expecting users to come to clinics. Nurses set up folding tables and treated wounds while patients stood on the sidewalk, working efficiently to clean, debride, and dress injuries in environments that were far from sterile but were better than no care at all. The program treated roughly 300 patients weekly by 2020, each requiring supplies that cost the organization $15 to $30 per wound. The mobile wound care model demonstrated both the possibilities and limitations of harm reduction approaches. Nurses could clean wounds and slow deterioration, but they couldn't perform the extensive surgical debridements that severe cases required. They could distribute antibiotics, but oral antibiotics achieved limited tissue penetration in ischemic wounds with poor blood supply. They could educate patients about wound care and provide supplies for home management, but patients living in encampments or abandoned buildings had nowhere clean to change dressings and no way to store medical supplies securely. Advanced wound care technologies developed for diabetic ulcers and battlefield injuries found new applications in Xylazine treatment. Negative pressure wound therapy systems, vacuum devices that promote healing by removing fluid and stimulating tissue growth, showed moderate effectiveness when patients could maintain the systems properly. The devices required electricity to run the pump, clean conditions to prevent infection, and the ability to keep dressings attached for days at a time. Few active drug users had access to electricity, cleanliness, or the executive function needed to maintain complex medical equipment. The technology worked well in controlled hospital settings, but failed in the chaotic environments where most Xylazine users actually lived. Hyperbaric oxygen therapy was attempted at several medical centers based on its effectiveness for diabetic wounds and radiation necrosis. The theory held that exposing patients to pure oxygen at elevated atmospheric pressure would force oxygen into ischemic tissue and promote healing. Results were disappointing because Xylazine-induced vasoconstriction prevented oxygen delivery regardless of how much oxygen saturated the blood. Putting patients in hyperbaric chambers for 90-minute sessions at costs exceeding $1,000 per treatment achieved minimal benefit and was quickly abandoned except in rare cases where patients had been abstinent long enough for vascular function to recover. Research into Xylazine-specific treatments proceeded slowly due to funding limitations and pharmaceutical industry disinterest. Universities could apply for federal grants to study the problem, but drug development required private sector investment that wasn't forthcoming. Companies developing addiction treatments focused on opioid antagonists and agonists, where markets were large and patent protection strong. No pharmaceutical company wanted to invest millions in developing a Xylazine reversal agent that would be given away for free by harm reduction programs and would face immediate generic competition because the underlying chemistry was decades old and unpatentable. Dr. Joseph D'Orazio at Temple led one of the few academic research efforts investigating treatment protocols from 2018 through 2022. His team developed staging criteria for Xylazine wounds, creating a classification system that helped physicians communicate about severity and guide treatment decisions. Stage 1 wounds showed discoloration and early ischemia, but intact skin. Stage 2 involved partial thickness tissue loss. Stage 3 featured full thickness necrosis. Stage 4 exposed bone, tendon, or joint structures. The staging system allowed data collection across hospitals and created frameworks for comparing outcomes, though it did nothing to solve the fundamental problem that no truly effective treatment existed. Clinical trials of potential interventions faced ethical and practical obstacles. Enrolling active drug users in studies required navigating complex consent issues, maintaining contact with highly unstable populations, and ensuring that study participation didn't worsen outcomes. Randomized controlled trials, the gold standard of medical research, seemed unethical when one group received experimental treatment and the control group received standard care that everyone knew was inadequate. Yet without rigorous trials, evidence for effective interventions remained weak, leaving physicians to practice medicine based on anecdote and intuition rather than scientific proof. The financial burden on individual patients destroyed lives even when medical treatment saved limbs. A 40-day hospital stay for wound care with multiple surgeries, intravenous antibiotics, and pain management generated bills ranging from $150,000 to $300,000. Patients with private insurance faced deductibles and copays that could reach tens of thousands of dollars. Those on Medicaid received care but often faced harassment from hospital billing departments and collection agencies pursuing the portion Medicaid didn't cover. Uninsured patients simply declared bankruptcy or ignored bills entirely, knowing their credit was already destroyed and they had no assets to seize. Hospital systems absorbed massive financial losses treating xylazine complications because reimbursement rates failed to cover costs of extended hospitalization and complex surgical care. Temple University Hospital reported spending more than $8 million in unreimbursed care for xylazine wound patients during 2020 alone. This figure didn't include emergency department visits or outpatient clinic costs, only inpatient hospitalization. Multiplying across hundreds of hospitals in affected regions suggested aggregate costs exceeding $1 billion annually for a completely preventable epidemic caused by economic incentives favoring drug adulteration over public health. Healthcare worker burnout reached crisis levels among staff treating xylazine patients repeatedly for the same problems. Emergency nurses saw identical patients weekly or monthly, each visit representing another infection, another necrotic wound, another overdose. The emotional toll of providing excellent care only to watch patients leave and immediately return to using drugs that would undo all medical intervention proved overwhelming. Some nurses transferred to different departments to escape the futility. Others developed compassion fatigue, becoming hardened and cynical toward patients they once tried to help. A few maintained empathy through years of disappointment, but they were exceptions sustained by personal resilience rather than institutional support. The COVID-19 pandemic strained already overwhelmed hospitals precisely when xylazine was reaching peak prevalence in many regions. During 2020 and 2021, hospitals faced surges of critically ill COVID patients while simultaneously treating the ongoing flow of xylazine complications. Intensive care beds needed for respiratory failure were occupied by overdose patients requiring prolonged ventilation. Surgical teams needed for COVID emergencies were performing wound debridements. Personal protective equipment shortages meant wound care staff treating patients with MRSA-colonized ulcers lacked adequate gowns and gloves. The convergence of two major health crises created conditions where neither could be addressed adequately. Telemedicine's expansion during COVID offered minimal benefit for xylazine wound care because the problem required hands-on intervention. A physician could evaluate wounds through video consultation and prescribe antibiotics remotely, but debridement requires a scalpel, and bleeding tissue cannot be properly assessed through a camera. Some wound clinics attempted hybrid models where nurses performed in-person care under remote physician supervision, but this arrangement satisfied legal requirements without improving outcomes. The fundamental limitation was that xylazine necrosis demanded intensive medical intervention that no technology could deliver remotely. Long-term outcomes remained grim even for patients who received optimal care. Follow-up studies tracking wound patients found that 70% experienced wound recurrence within 12 months if they continued using xylazine-contaminated drugs. Among those who achieved abstinence, roughly 40% maintained healed wounds, 30% had chronic wounds requiring ongoing management, and 30% eventually required amputation despite initial successful treatment. These statistics illustrated the brutal reality. Medical science could delay xylazine's damage, but rarely prevented it entirely, unless patients stopped using the drug completely and permanently. The healthcare system's failure to address xylazine effectively wasn't due to lack of medical knowledge or physician effort, but rather reflected structural problems that transcended any individual hospital's capabilities. Treating xylazine complications successfully required combining acute care, long-term wound management, addiction treatment, mental health services, housing support, and economic assistance, none of which existed in coordinated or adequately funded forms. Hospitals could treat wounds but couldn't house patients after discharge. Addiction programs could offer counseling but couldn't prescribe effective medications for xylazine withdrawal because none existed. Mental health services could address depression but couldn't overcome the despair caused by watching your own flesh die. The system was designed to treat diseases, not the social and economic conditions that made xylazine attractive despite its catastrophic consequences, and this fundamental mismatch guaranteed that medical responses would remain inadequate no matter how dedicated individual healthcare workers proved to be. Harm reduction organizations operating outside traditional medical and legal frameworks became the frontline responders to xylazine's devastation, filling gaps that government agencies and hospitals either couldn't or wouldn't address. These groups had been distributing clean needles and naloxone for years, working in legal grey areas where law enforcement tolerated their activities as preferable to HIV epidemics and overdose deaths. Xylazine required them to expand far beyond their original missions, transforming needle exchanges into impromptu wound care clinics and training street outreach workers to recognize tissue necrosis that most physicians had never encountered. Prevention Point. Philadelphia pioneered the harm reduction response to tranq wounds starting in 2012, initially with just wound care supplies added to their needle exchange services. Staff noticed clients showing up with horrifying injuries, blackened fingers, ulcerated legs, wounds that smelled of death, and realized that clean syringes alone wouldn't address this new dimension of drug-related harm. The organization assembled wound care kits containing sterile gauze, antibiotic ointment, medical tape, gloves, and instructions written in simple language explaining how to clean wounds and when to seek emergency care. Distribution began modestly with 50 kits weekly, but by 2015 the organization was handing out 300 kits weekly and still couldn't meet demand. Sarah Laurel, a nurse who had worked in trauma surgery before joining Prevention Point's harm reduction team in 2014, brought clinical expertise to street-level intervention. She trained outreach workers to perform basic wound assessment using a color-coded triage system. Red for wounds requiring immediate emergency department referral, yellow for wounds needing clinic follow-up, green for wounds manageable with self-care. The system was crude but effective, allowing non-medical staff to make rapid decisions about which clients needed immediate intervention versus those who could be safely monitored. Laurel performed wound cleaning and basic debridement herself during outreach shifts, standing on Kensington Avenue corners with a folding table covered in medical supplies. Peer support specialists, people in recovery who had personally experienced addiction and often had survived xylazine wounds themselves, proved more effective than medical professionals at reaching active users with health information. Miguel Santos, who had lost 3 toes to trank necrosis before achieving sobriety in 2016, became one of Prevention Point's most valuable staff members precisely because he could show clients his prosthetic digits and say, "This is where this drug leads." His credibility came from lived experience rather than credentials, and users who would dismiss advice from doctors or nurses listened when Santos explained wound care protocols. The philosophical foundation of harm reduction, meeting people where they are without demanding abstinence, allowed these programs to provide services that traditional medical and addiction treatment systems couldn't offer. Users could access wound care without answering questions about their drug use, receive antibiotics without lectures about quitting, and get referrals to treatment only if they asked for them. This non-judgmental approach built trust with a population that had been stigmatized and marginalized by every other social institution. Clients knew that harm reduction sites were safe spaces where they wouldn't be arrested, shamed, or turned away. Needle exchange programs adapted their services to include xylazine-specific education materials. Information cards distributed with syringes explained that trank dope could cause severe wounds, that naloxone only partially reversed overdoses involving xylazine, and that tissue damage often appeared far from injection sites. The materials avoided medical terminology, using street language and clear descriptions. If your skin turns grey or purple, you need to see a doctor immediately. This can lead to amputation. Graphics showed wound progression from early discoloration to full necrosis, giving users visual references for recognizing dangerous symptoms. Drug checking services expanded to include xylazine detection, though the technology required was expensive and not widely available. Organizations with funding purchased Fourier transform infrared spectrometers, or Raman spectrometers, capable of identifying xylazine in drug samples. Users could bring small portions of their drugs for testing, receiving results that confirmed or denied xylazine presence, along with estimates of concentration. Testing revealed the grim reality. By 2018 in Philadelphia, more than 80% of tested heroin samples contained xylazine. Users seeking xylazine-free heroin had essentially no options available in the local market. Mobile wound care clinics brought medical intervention directly to encampments and street corners where traditional healthcare couldn't reach. A retrofitted van operated by Philadelphia's health department, in partnership with Prevention Point, travelled to known drug use locations, offering wound cleaning, basic debridement, antibiotic prescriptions, and tetanus shots. The van's presence 3 days weekly in Kensington meant clients didn't need to travel to clinics or emergency departments, reducing a major barrier to care. Patients treated in the mobile clinic were more likely to return for follow-up, because the service came to them rather than requiring them to navigate transportation and bureaucracy. Social media became an unexpected tool for harm reduction, as users formed Facebook groups and Reddit communities sharing information about xylazine wounds. These online spaces featured graphic photographs of injuries at various stages, allowing users to compare their own wounds to others' experiences and gauge severity. Discussion threads debated wound care techniques, recommended products, and shared stories of both successful healing and catastrophic deterioration. The communities were democratized information networks where a homeless person in Philadelphia could advise a suburban teenager in Connecticut based on hard-won experience surviving trank wounds. The peer knowledge networks disseminated practical information that clinical studies had yet to document. Users discovered that keeping wounds covered and moist promoted healing better than allowing them to dry out and scab over. They learned that certain over-the-counter antibiotic ointments worked better than others. They shared sources for cheap medical supplies and identified emergency departments that treated drug users respectfully versus those that provided substandard care. This crowdsourced medical knowledge was methodologically dubious, but pragmatically valuable in an environment where professional medical care was often inaccessible. Tensions emerged between harm reduction's non-judgmental philosophy and the reality that continued xylazine use guaranteed wound recurrence. Workers struggled with the ethical complexity of providing excellent wound care while knowing that clients would leave and inject more tranq dope that same day, undoing all medical intervention. Some staff advocated for making services conditional on attempts at sobriety, while others insisted that any conditions would drive away the most vulnerable clients who needed help most desperately. The philosophical debates were never fully resolved, with most organizations maintaining unconditional service provision while experiencing moral exhaustion from the apparent futility. Funding for harm reduction programs remained catastrophically inadequate relative to the crisis's scale. Prevention Point Philadelphia operated on an annual budget of approximately $2 million in 2020, serving thousands of clients with needs including needle exchange, naloxone distribution, wound care, HIV testing, hepatitis C treatment, and case management. The organization relied on a patchwork of city grants, private donations, and occasional federal funding that could be eliminated at any time. Staff worked for salaries well below what their skills could command elsewhere, sustained by commitment to the mission rather than financial compensation. Legal harassment complicated harm reduction work, even in jurisdictions where needle exchanges operated with official sanction. Police officers sometimes arrested clients immediately after they left harm reduction sites, viewing the locations as convenient places to find people with outstanding warrants or drug possession charges. These arrests destroyed the trust and safety that harm reduction sites tried to create, making clients fearful of accessing services. Some cities required harm reduction organizations to maintain lists of clients receiving services, creating surveillance that users rightfully viewed as threatening and that deterred the most vulnerable individuals from seeking help. Naloxone distribution increased exponentially as overdoses involving xylazine became ubiquitous, though the drug's limitations in reversing veterinary sedative effects became frustratingly clear. Harm reduction programs distributed tens of thousands of naloxone kits annually, training users and their families in administration. The training now included warnings that naloxone would only partially reverse tranq dope overdoses, and that prolonged medical observation was essential. Some users reported administering 4 or 5 doses of naloxone to overdosing friends before achieving adequate response, far exceeding the 1 or 2 doses typically needed for heroin or fentanyl alone. Community organizing efforts brought xylazine into public consciousness through activism that mainstream media had largely ignored. Harm reduction advocates organized demonstrations in front of city halls and state capitals, demanding funding for treatment and infrastructure. Clients willing to share their stories spoke at public forums, displaying wounds and describing their experiences with tranq dope. These testimonies humanized statistics that might otherwise have been dismissed as just another drug problem, affecting people that society preferred to forget. The organizing created political pressure that resulted in some policy changes, though resources never matched the crisis's magnitude. The COVID-19 pandemic forced rapid innovation in harm reduction service delivery when lockdowns and social distancing requirements threatened to shut down in-person programs. Organizations shifted to delivery models, bringing supplies directly to clients' homes or meeting them in outdoor locations. Some established telephone hotlines where users could request emergency wound care or naloxone deliveries. The adaptations demonstrated that harm reduction could function even under extreme constraints, but they also highlighted how much in-person contact mattered. Nurses couldn't assess wounds over the phone, and the community connections built through face-to-face interactions at exchange sites couldn't be replicated remotely. Training programs transformed ordinary citizens into capable harm reduction workers, spreading expertise beyond professional organizations. Naloxone training sessions taught participants how to recognize overdose symptoms, administer the reversal agent, and provide rescue breathing. Wound care workshops covered basic principles of cleaning injuries, applying dressings, and identifying complications requiring professional medical intervention. These trainings created decentralized networks of people equipped to respond to xylazine-related emergencies without relying on overwhelmed emergency services. A grandmother who completed naloxone training could potentially save her grandson's life. A roommate who learned wound care could prevent minor injuries from progressing to amputations. Supervised consumption sites, facilities where users could inject drugs under medical supervision, operated in other countries but remained largely illegal in the United States despite evidence of effectiveness. Philadelphia seriously considered authorizing such sites around 2018, but legal challenges and federal opposition prevented implementation. These sites could have provided immediate wound care, overdose response, and treatment referrals in controlled environments where users weren't isolated and dying alone. The failure to implement supervised consumption represented another missed opportunity, where ideology and politics prevented evidence-based interventions that could have saved lives and limbs. Harm reduction workers experienced vicarious trauma from constant exposure to human suffering that they could ameliorate but not prevent. Staff members formed relationships with clients over months and years, watching them deteriorate despite everyone's best efforts. A client whose wounds had been healing would disappear for weeks, then return with new necrosis. Someone who'd been doing well would overdose fatally, and workers would learn about the death through street gossip or newspaper obituaries. The cumulative emotional toll created high turnover in a field that already struggled with low pay and difficult working conditions. Those who remained long-term developed either remarkable resilience or carefully maintained emotional distance that protected them psychologically but reduced their empathy. The underground harm reduction response demonstrated both the power and limitations of community-based intervention. These organizations reached people that no other system could touch, and provided services that probably saved thousands of lives and limbs. They operated efficiently with minimal bureaucracy and adapted quickly to changing conditions. Yet they couldn't address root causes of why people used xylazine-contaminated drugs in the first place. The poverty, trauma, lack of opportunity, and social dislocation that made oblivion attractive despite catastrophic physical consequences. Harm reduction could make drug use safer, but couldn't make people want to stop using or create conditions where sobriety seemed like a better option than the temporary escape that tranq dope provided. The movement had won tactical victories while losing the strategic war against a drug epidemic that no amount of wound care kits and naloxone could ultimately defeat. Federal recognition of xylazine as a national crisis came years after street-level harm reduction workers had been sounding alarms, illustrating the bureaucratic lag between grassroots reality and official acknowledgement. The Drug Enforcement Administration first mentioned xylazine in internal reports around 2015, noting its presence in seized drugs as an unusual finding worthy of monitoring but not immediate action. By 2019, DEA field offices in Philadelphia and Baltimore were filing reports describing xylazine as a significant adulterant, but the agency's focus remained on fentanyl and methamphetamine as the primary threats. The veterinary sedative was treated as a curiosity rather than a crisis, until the death toll became impossible to ignore. The FDA occupied an awkward position because xylazine remained a legitimate and necessary veterinary medication. The agency regulated the drug's manufacture and approved its use in animals, but restricting access would harm veterinary medicine without necessarily impacting illicit drug supplies flowing from Mexico and China. FDA officials understood that most xylazine entering drug markets wasn't being diverted from veterinary clinics, but rather manufactured specifically for trafficking organizations. Cracking down on American veterinarians wouldn't stop Mexican cartels from importing bulk powder from overseas suppliers. The regulatory tools available were poorly matched to the problem's actual structure. Pennsylvania became the first state to take concrete legislative action in 2021 by requiring mandatory reporting of xylazine-positive overdose cases to state health authorities. The law created a surveillance system that documented the crisis's scale but offered no solutions. Hospitals and medical examiners filed reports showing xylazine's presence in 70 to 90% of overdoses in some counties, generating statistics that confirmed what everyone already knew while doing nothing to prevent additional deaths. The data collection served bureaucratic needs for documentation, but lacked mechanisms for intervention. Ohio attempted a more aggressive approach in 2022 by classifying xylazine as a dangerous drug and requiring DEA registration for purchases above certain quantities. Veterinarians could still obtain the drug through normal prescription procedures, but bulk purchases that might supply drug dealers faced additional scrutiny. The law sounded comprehensive but achieved minimal impact because legitimate veterinary supply chains weren't the primary source of illicit xylazine. Dealers simply shifted entirely to black market sources, leaving Ohio's regulatory framework regulating a supply chain that wasn't feeding the crisis. The DEA faced political pressure to schedule xylazine as a controlled substance under the Controlled Substances Act, which would make unauthorized possession and distribution federal crimes. Scheduling seemed like a simple solution: criminalize the drug and prosecute people who sell it. The reality was far more complex. Veterinary organizations lobbied intensely against scheduling, arguing it would create unnecessary regulatory burdens for legitimate animal medicine. Law enforcement experts noted that scheduling wouldn't stop Mexican and Chinese manufacturers from producing xylazine for illicit markets. Public health officials warned that criminalization might push dealers toward even more dangerous adulterants to replace xylazine. International cooperation efforts to restrict xylazine manufacturing faced diplomatic and practical obstacles. China produced most of the world's pharmaceutical-grade xylazine through factories operating legally under Chinese law. The United States requested that Chinese authorities crack down on these manufacturers, but China's regulatory system prioritized domestic concerns over American drug policy preferences. Factories that produced veterinary xylazine for legitimate global markets were difficult to distinguish from those diverting product to traffickers. Chinese officials reasonably asked why their country should restrict legal pharmaceutical production because Americans had drug problems. Mexico's role as the final processing and transshipment point meant cartels added xylazine to heroin and fentanyl at facilities the Mexican government couldn't effectively monitor or shut down. These weren't large industrial operations vulnerable to detection, but rather small labs that could move locations quickly when threatened by law enforcement. The Mexican government was already fighting a multi-front war against cartels and had limited resources or political will to prioritize a drug that primarily harmed Americans rather than Mexicans. Diplomatic pressure achieved polite assurances of cooperation that translated into minimal on-the-ground enforcement. The Biden administration's response crystallized in April 2023 when the Office of National Drug Control Policy designated xylazine as an emerging drug threat, the first time the federal government had used this designation for any substance. The declaration came with $50 million in funding for research, treatment, and education, a sum that seemed substantial until distributed across federal agencies and state programs. The money-funded pilot programs, academic studies, and harm reduction initiatives, but it was a drop in the bucket relative to a crisis affecting hundreds of thousands of people and causing billions in medical costs and lost productivity. Congress held hearings on Xylazine throughout 2022 and 2023, with legislators expressing shock and outrage at testimony describing flesh-eating wounds and soaring death rates. These hearings followed the traditional pattern of congressional drug crisis responses: emotional testimonies, tough questions for agency officials, promises of action, and ultimately minimal substantive change. The political incentives favoured appearing concerned without spending the massive resources that actually addressing the problem would require. Funding addiction treatment at levels that might make a difference would cost hundreds of billions of dollars annually, far more than any Congress would appropriate for a stigmatized population of drug users. State legislatures across the country introduced bills addressing Xylazine, creating a patchwork of inconsistent regulations that reflected different priorities and political pressures. Connecticut passed laws requiring hospitals to stock atipamezole and training first responders in its use. Maryland mandated Xylazine education in medical schools and nursing programs. Massachusetts created a Xylazine task force to coordinate state agency responses. These measures were reasonable but insufficient, addressing symptoms rather than causes. No state had the resources or authority to dismantle international drug trafficking networks or create the economic conditions where people might choose sobriety over oblivion. The scheduling debate intensified throughout 2023 as law enforcement agencies pushed for Xylazine to be classified as a Schedule III controlled substance, the same category as ketamine and anabolic steroids. This classification would make unauthorized possession a crime while allowing continued veterinary use under prescription. The DEA initiated the regulatory process, soliciting public comments and conducting analysis. Veterinary associations submitted detailed objections. Harm reduction organizations argued that criminalization would worsen outcomes, and law enforcement claimed scheduling was essential for prosecution. The comment period generated thousands of submissions representing irreconcilable positions. Prosecution of Xylazine cases under existing law faced technical obstacles because adulterating drugs wasn't clearly criminal unless the adulterant itself was illegal or unless prosecutors could prove intent to cause harm. A dealer caught with heroin cut with Xylazine faced charges only for the heroin, with Xylazine presence treated as an aggravating factor at sentencing rather than a separate crime. Some prosecutors attempted to charge dealers with assault or manslaughter when customers developed wounds or died, but proving causation was difficult when victims had often purchased from multiple dealers and used various drugs in combination. Federal funding for addiction treatment remained woefully inadequate, even as Xylazine complicated clinical practice and required longer, more intensive interventions. Substance abuse treatment programs operated with wait lists stretching weeks or months, meaning people ready to quit couldn't access services when motivated. Insurance reimbursement rates for addiction treatment were so low that many facilities couldn't afford to accept insurance and required cash payment up front. Medicaid paid for some treatment, but with restrictions and limitations that made comprehensive care difficult. The system was designed to fail expensive chronic conditions like addiction. Pharmaceutical industry involvement in developing Xylazine-specific treatments remained minimal despite obvious need and potentially substantial markets. The economics didn't work from a business perspective. Developing a reversal agent would cost hundreds of millions of dollars, require FDA approval through lengthy clinical trials, and result in a product that would be distributed free through harm reduction programs or purchased in small quantities by hospitals. Generic manufacturers could immediately copy any reversal agent because the underlying chemistry was known and unpatentable. No company would invest massive capital for minimal return, so the research didn't happen. Academic researchers filled some of the pharmaceutical industry's absence, conducting studies on shoestring budgets with grant funding from NIH and CDC. These studies documented xylazine's effects, tracked its spread, and explored potential interventions, but academic research moved slowly and lacked the resources for large-scale clinical trials. A university lab might study whether a particular drug reduced xylazine-induced vasoconstriction in rat models, but translating those findings into human medication required pharmaceutical industry participation that wasn't forthcoming. The knowledge gap between understanding xylazine's mechanism and having effective treatments remained unbridged. Regulatory agencies discovered they had jurisdictional gaps and overlapping responsibilities that prevented coordinated response. The DEA handled drug scheduling and enforcement. The FDA regulated pharmaceutical manufacturing. The CDC tracked disease outbreaks and mortality. SAMHSA funded addiction treatment programs. Each agency operated independently with different mandates, priorities, and constraints. Interagency coordination happened through committees and working groups that produced reports and recommendations but lacked authority to compel action. The federal government's response was fragmented by design, with no single entity responsible for comprehensive drug policy. International treaties governing drug control, established in the 1960s and 1970s, never anticipated veterinary medications becoming street drugs. The UN Single Convention on Narcotic Drugs and the Convention on Psychotropic Substances listed classic drugs of abuse, but had no framework for addressing pharmaceutical and veterinary compounds that migrated into illicit markets. Updating these treaties required consensus among signatory nations with divergent interests and priorities. Countries producing xylazine for legitimate veterinary use had no incentive to support international restrictions that would harm their pharmaceutical export industries. The regulatory scramble produced volumes of rules, reports, and initiatives that collectively changed very little about xylazine's availability or prevalence. Each agency and legislative body did what fell within its authority and political constraints, generating activity that looked like progress without achieving substantive results. Laws were passed, regulations issued, task forces convened, funding allocated, and agencies coordinated. Meanwhile, xylazine remained readily available to anyone who wanted it, continued appearing in 80+% of heroin samples in high prevalence areas, and kept destroying bodies faster than medical care could repair them. The gap between governmental response and actual problem illustrated a fundamental truth about drug policy. Systems designed for one era's drugs are structurally incapable of addressing the next generation's challenges, and by the time regulations catch up to reality, the crisis has evolved further and the regulatory targets have shifted. Xylazine wasn't scheduled as a controlled substance until late 2023, more than 20 years after it first appeared in Puerto Rican drug supplies, and by then the damage had been done, the drug was entrenched in national supply chains, and scheduling accomplished little beyond giving prosecutors another charge to file after the fact. Individual lives destroyed by xylazine formed patterns that repeated with minor variations across demographics, geographies, and social classes. A 24-year-old woman from suburban Connecticut started using prescription opioids after a car accident in 2016, switched to heroin when her prescription ran out in 2017, and encountered tranq dope in 2019 without knowing what made the new supply feel different. The progression from recreational use to daily dependency took 18 months. Her first wound appeared on her left forearm in early 2020. a small grey patch she dismissed as a bruise until it opened into an ulcer that exposed muscle tissue. 3 debridement surgeries and 6 weeks of hospitalization followed, draining her family's savings and her parents' retirement accounts to cover medical bills that insurance rejected as addiction-related. Parents watching children deteriorate faced impossible choices between enabling continued drug use and enforcing boundaries that might result in homelessness or death. A father in Philadelphia discovered his son injecting in the family bathroom in 2018, the syringe still in his arm and black necrotic tissue visible on his ankle. The father threw his son out, believing tough love would force sobriety. 3 months later, he found his son living in a Kensington encampment with wounds on both legs so severe that bone was visible. The choice between principles and pragmatism destroyed families regardless of which option parents chose. Enabling meant watching loved ones die slowly at home. Rejection meant imagining them dying alone on the street. Employment became impossible for users with visible disfigurement from tranq wounds. A 32-year-old former construction worker in Baltimore lost fingers on both hands to xylazine necrosis, making it physically impossible to grip tools or perform manual labor. His applications for disability benefits were initially denied because addiction wasn't considered a qualifying condition, and the amputations were deemed drug-related rather than legitimate medical disability. He spent 2 years appealing while surviving through panhandling and stealing, accumulating criminal charges that further reduced his employment prospects, even if his hands had been functional. The criminal justice system processed xylazine users with bureaucratic efficiency that took no account of medical complications. A woman arrested for shoplifting in Connecticut had active necrotic wounds on her legs that required daily dressing changes and antibiotics. Jail medical staff provided minimal wound care, changing dressings weekly rather than daily, and offering only over-the-counter pain relief despite tissue damage severe enough to warrant opioid analgesics. Her wounds worsened during 60 days of incarceration, progressing from stage 2 to stage 4 necrosis. Upon release, she required immediate hospitalization and eventual below-knee amputation of her right leg. Children watched parents choose drugs over healing in scenarios that inflicted multi-generational trauma. An 8-year-old boy in Pennsylvania lived with his mother who used tranq dope and had chronic wounds on her arms and legs. The child learned to change his mother's dressings when she was too high to do it herself, cleaning necrotic tissue and applying gauze while his mother nodded in and out of consciousness. Child Protective Services eventually removed him from the home, but the psychological damage from years of parentifying a child and exposing him to graphic medical trauma was already permanent. Housing instability and homelessness made wound management practically impossible, and guaranteed progression from minor injuries to major complications. Users living in encampments or abandoned buildings had no access to clean water for wound washing, no refrigeration for antibiotic storage, no secure place to keep medical supplies that wouldn't be stolen. Dressings became soaked with dirt and contamination within hours in outdoor environments. Infections that could have been prevented with basic hygiene flourished in conditions where people slept in their own filth and lacked facilities for bathing or laundry. Economic destruction accompanied physical deterioration as medical debt accumulated faster than any reasonable possibility of repayment. Hospital bills for wound care and amputations range from $100,000 to $300,000 per episode, and users often had multiple hospitalizations. Collections agencies pursued these debts aggressively, garnishing wages, seizing bank accounts, and filing lawsuits that resulted in default judgments. Credit scores plummeted, making it impossible to rent apartments, obtain utilities, or access the financial infrastructure that middle-class life required. People who had been functional members of society became permanently excluded from economic participation. Social isolation intensified as visible disfigurement and the smell of necrotic tissue made users pariahs. Friends stopped visiting, unwilling to witness the deterioration or endure the odor. Family members maintained emotional distance to protect themselves from trauma. Romantic relationships dissolved when partners couldn't cope with watching someone's body decompose. The isolation drove users deeper into drug use, as the only available source of comfort and social connection came from other users who shared similar experiences. Addiction support networks that might have provided paths toward recovery were inaccessible to people too ashamed of their wounds to attend meetings. Recovery success stories existed but were rare enough to highlight how difficult escape had become. A 41-year-old man in Philadelphia achieved sobriety in 2021 after 5 years of tranq dope use that cost him 7 toes and portions of both ears. He entered treatment after nearly dying from sepsis related to infected wounds, spending 4 months in inpatient rehabilitation, followed by 18 months of outpatient care. His recovery required comprehensive support, subsidized housing, vocational training adapted to his physical limitations, ongoing wound care, and a prosthetic device allowing him to walk without constant pain. Even with all these resources, his sobriety remained fragile and required constant effort to maintain. Some individuals who achieved recovery became advocates and peer support specialists, channeling their trauma into helping others. Their stories of survival and rehabilitation provided hope in an otherwise bleak landscape. They spoke at harm reduction events, testified at legislative hearings, and worked directly with active users as living proof that escape was possible. Yet their success was predicated on access to resources and support that most users lacked. Recovery required not just individual willpower, but comprehensive systems of care that existed only sporadically and served tiny fractions of those who needed them. The death toll from xylazine-involved overdoses climbed steadily, though exact numbers remained uncertain because medical examiners didn't always test for the drug and reporting standards varied by jurisdiction. Conservative estimates suggested at least 3,000 Americans died annually from overdoses involving xylazine by 2022. But this figure captured only deaths where testing occurred and excluded people who died from complications like sepsis or cardiac arrest related to chronic xylazine use rather than acute overdose. The true mortality was likely double or triple the official count. Demographics of xylazine users defied stereotypes about drug addiction, affecting only marginalized populations. Suburban teenagers experimenting with pills bought from classmates died with xylazine in their systems because the pills were counterfeit fentanyl pressed in Mexican labs and contaminated with veterinary sedative. Middle-aged professionals using cocaine recreationally developed wounds because their powder contained xylazine from cross-contamination in processing facilities. Elderly patients with chronic pain conditions bought street drugs when doctors wouldn't prescribe adequate pain relief and discovered too late that their heroin contained the zombie drug. The psychological torture of conscious awareness while your body rots created mental health emergencies that addiction treatment programs weren't equipped to address. Traditional therapy approaches focused on identifying triggers, developing coping mechanisms, and building support systems, none of which adequately addressed the existential horror of watching your fingers turn black and die while you remained fully alert. Some users developed symptoms resembling PTSD, intrusive thoughts about wounds, hypervigilance about any skin changes, avoidance of mirrors or reflective surfaces. The trauma compounded addiction because using drugs was the only way to achieve temporary escape from the mental anguish of physical deterioration. Amputees faced unique challenges that extended beyond physical adaptation to prosthetics. The phantom limb pain from missing fingers or toes was intensified by the fact that the tissue had died gradually, rather than being suddenly removed through trauma. Neurological pathways had time to wire in pain signals from degenerating tissue, creating chronic pain syndromes that persisted long after amputation. Some amputees reported feeling their missing digits rotting even after surgical removal, experiencing phantom necrosis that no pain medication adequately treated. Family impact rippled outward through generations and social networks. Siblings watched brothers and sisters die or become permanently disabled, creating survivors' guilt and fear about their own vulnerability to addiction. Grandparents found themselves raising grandchildren whose parents were too consumed by addiction to function as caregivers. The financial costs of supporting an addicted family member drained resources that might have funded education, retirement, or other family members' needs. Every person destroyed by Xylazine affected dozens of others through webs of relationship and responsibility. The cruelest aspect of Xylazine addiction was that users understood exactly what was happening to them, but felt powerless to stop. This wasn't ignorance or denial. It was the fundamental nature of addiction overriding rational self-preservation. Users looked at their rotting limbs, understood they were dying, acknowledged they should quit, and then injected more tranq dope because the immediate relief from withdrawal outweighed future consequences that seemed abstract despite being visibly manifested in their own flesh. The drug had hijacked decision-making processes so thoroughly that even imminent death or amputation wasn't sufficient motivation to quit. Stories of recovery after amputation illustrated both resilience and tragedy. A 28-year-old woman who lost her left leg below the knee achieved sobriety and rebuilt her life, learning to use a prosthetic and eventually returning to work as a pharmacy technician. She spoke publicly about her experience, showing her prosthetic leg at high school assemblies to warn students about drug dangers. Yet she also acknowledged in interviews that chronic pain from the amputation site sometimes made her consider relapse as an escape from physical suffering. Recovery wasn't a final destination, but an ongoing struggle that required daily recommitment despite permanent physical consequences. The aggregate human toll was measured not just in deaths and amputations, but in the sum of suffering, fear, shame, and loss that rippled through communities. Thousands of people were living with chronic wounds requiring daily care. Tens of thousands more had survived Xylazine use but carried permanent scars, lost tissue, or psychological trauma. Hundreds of thousands of family members and friends experienced vicarious trauma from watching loved ones deteriorate. The veterinary drug had created a public health catastrophe whose full impact wouldn't be quantifiable for decades, if ever, because so much of the damage was invisible. The dreams abandoned, relationships destroyed, potential unrealized, and psychic wounds that would never fully heal. Laboratory testing data from 2023 and 2024 confirmed that Xylazine had achieved near-total market saturation in many regions, transforming from adulterant to standard ingredient in the illicit opioid supply. Philadelphia's drug checking services found Xylazine in 94% of heroin samples and 78% of fentanyl samples analyzed during the first half of 2024. Baltimore recorded similar figures. 89% of opioid samples contained the veterinary sedative. The drug had become so ubiquitous that finding xylazine-free heroin was statistically more remarkable than finding contaminated product. Users seeking to avoid tranq dope had essentially no viable options within local markets. Geographic spread continued relentlessly into regions that had been relatively spared during the initial wave. Arizona documented substantial xylazine presence in Phoenix's drug supply by late 2023, with concentrations reaching 30 to 40% of tested samples by mid-2024. New Mexico reported similar invasion patterns in Albuquerque. Nevada found the drug in Las Vegas samples at rates climbing from 5% in early 2023 to 25% by late 2024. The western United States, which had initially seemed protected by different trafficking patterns and fentanyl dominance, was experiencing the same transformation that had devastated the East Coast 5 years earlier. Mortality statistics revealed Xylazine's contribution to the ongoing overdose crisis with disturbing clarity. CDC data showed that approximately 3,400 deaths in 2022 involved Xylazine, representing roughly 7% of all drug overdose fatalities. By 2023, that figure increased to approximately 4,800 deaths, 10% of the total. Early 2024 data suggested the trend was accelerating rather than stabilizing. These numbers almost certainly undercounted true mortality because many jurisdictions didn't routinely test for Xylazine, and deaths from complications like sepsis or cardiovascular collapse might not be attributed to the drug, even when it was the underlying cause. Medical approaches to Xylazine wounds evolved through clinical experience, though fundamental treatment challenges remained unresolved. Specialized wound clinics developed protocols combining aggressive debridement, negative pressure therapy, and prolonged antibiotic coverage. Some facilities experimented with maggot therapy, using sterile larvae to consume necrotic tissue, with modest success in cases where traditional debridement proved insufficient. Hyperbaric medicine showed limited benefit except in patients who had achieved abstinence long enough for vascular function to partially recover. The most effective intervention remained the most difficult to achieve: complete cessation of Xylazine-containing drug use. Research into Xylazine antagonists made incremental progress through academic institutions, despite pharmaceutical industry disinterest. Temple University researchers published studies in 2023 showing that atipamezole could reverse Xylazine's cardiovascular effects in humans when administered intravenously within hours of exposure. The findings suggested that emergency stockpiling of atipamezole might save lives during overdoses, but the drug's lack of FDA approval for human use and its high cost prevented widespread adoption. Some harm reduction organizations acquired veterinary atipamezole through underground channels and trained users in its administration, operating in legal grey areas that could result in prosecution. The fentanyl-xylazine combination that dominated drug supplies by 2024 represented a uniquely dangerous formulation that maximized both overdose risk and tissue damage. Fentanyl's potency meant that tiny variations in dose could mean the difference between adequate high and fatal overdose. Xylazine's prolongation of effects meant users stayed sedated longer, increasing exposure time to respiratory depression. The synergy created a product that was maximally addictive. Users described tranq dope as impossible to quit because withdrawal symptoms from both compounds overlapped and reinforced each other, producing dysphoria more severe than either drug alone. Supply chain evolution showed cartels refining production methods to maximize efficiency and profit. Intelligence reports indicated that major Mexican trafficking organizations had established dedicated Xylazine supply lines from Chinese manufacturers, with bulk shipments arriving at Mexican ports and transported to processing facilities in Culiacan and Guadalajara. The Xylazine was mixed with fentanyl at standardized ratios, typically 1 part Xylazine to 10 parts fentanyl by weight, creating consistent products that users recognized and preferred. Quality control in cartel operations had become sophisticated enough that dose consistency improved, reducing some overdose risk while ensuring predictable effects that built customer loyalty. Dark web markets continued facilitating Xylazine distribution on a smaller scale that supplemented traditional trafficking routes. Encrypted marketplaces sold xylazine powder with vendor ratings and customer reviews similar to legitimate e-commerce sites. Buyers could purchase quantities from 1 gram to multiple kilograms, shipped domestically to avoid customs inspection. Some vendors offered trank kits, containing pre-measured xylazine portions and instructions for cutting heroin or fentanyl, marketing their products to small-scale dealers. Cryptocurrency payment through Bitcoin or Monero provided anonymity that frustrated law enforcement efforts to track transactions or identify participants. Academic research expanded into multiple dimensions of the xylazine crisis as universities recognized the phenomenon as a significant public health emergency. Studies investigated epidemiology, tracking spread patterns and identifying risk factors. Clinical research explored treatment protocols for wounds and overdoses. Neuroscience laboratories examined xylazine's mechanism of action at molecular levels, hoping to identify intervention points. Sociology and anthropology departments conducted ethnographic research with user communities, documenting lived experiences and social contexts. The accumulating knowledge base was scientifically valuable, but provided limited immediate benefit to people currently dying or losing limbs. Harm reduction strategies adapted to xylazine's persistence rather than its elimination. Organizations distributed information about prolonged naloxone administration, multiple doses over extended periods, to address xylazine's long duration of action. Wound care education expanded to include early recognition of ischemic tissue damage before full necrosis developed. Some programs experimented with providing xylazine test strips that could detect the drug in samples before use, though the test value was questionable, given that users often had no alternative products available. The focus shifted from preventing xylazine exposure to minimizing harm from inevitable exposure. Drug policy debates incorporated xylazine as evidence for different ideological positions without reaching consensus on solutions. Prohibitionists argued that xylazine's devastation proved the need for stricter enforcement and harsher penalties for dealers. Harm reduction advocates pointed to the crisis as evidence that criminalization drove dangerous adulterants, and that decriminalization with regulated supply would prevent contamination. Neither position commanded sufficient political support for implementation, leaving policy in a paralyzed state where everyone agreed the situation was catastrophic, but no one could marshal the power to fundamentally change the approach. Safe supply programs, government provision of pharmaceutical-grade opioids to users, remained politically impossible in most of the United States despite evidence from Canadian programs showing reduced overdose deaths and wound complications. The ideological opposition to giving drugs to addicts overwhelmed evidence about effectiveness. A few pilot programs operated in California and Vermont, providing prescribed hydromorphone to a small number of participants with demonstrated inability to achieve abstinence. These programs showed promising results. Participants reduced illicit drug use, stabilized their lives, and had no xylazine exposure because pharmaceutical opioids contained no adulterants. But the program served hundreds of people in a country where hundreds of thousands needed similar services. International development showed xylazine spreading beyond North America into European drug markets. The United Kingdom documented its first xylazine deaths in 2022, with detections increasing throughout 2023 and 2024 in cities including London, Manchester, and Glasgow. Spain reported xylazine presence in drug samples from Madrid and Barcelona. The pattern suggested transnational trafficking organizations were exporting the American innovation to other markets, testing whether European users would accept xylazine-adulterated drugs. Early European response appeared more coordinated than America's fragmented reaction, with EU agencies issuing warnings and member states implementing detection protocols before the drug achieved widespread prevalence. Xylazine analogues and related compounds posed future threats as chemists modified the basic structure to evade regulation or enhance effects. Research chemicals forums discussed veterinary sedatives similar to xylazine, drugs like detamidine and medetamidine that acted on the same alpha-2 receptors with slightly different properties. If xylazine became too tightly controlled or difficult to source, traffickers could pivot to these alternatives with minimal disruption to supply chains. The game of regulatory whack-a-mole that had characterized synthetic cannabinoids and cathinones was beginning with veterinary sedatives, suggesting an endless series of crises as each controlled substance was replaced by a slightly modified alternative. The medical system's response had stabilized into a new baseline where xylazine complications were routine rather than exceptional. Emergency departments in high-prevalence areas treated tranq wounds as standard presentations, developing efficient protocols that triaged patients quickly and provided adequate care within resource constraints. The shock and novelty that characterized early responses had been replaced by grim acceptance. Healthcare workers no longer expressed surprise at wounds exposing bone or requiring amputation. They simply treated the cases with professional competence while acknowledging the futility of medical intervention when patients returned immediately to using the drugs that caused the injuries. Treatment capacity remained catastrophically inadequate relative to need. Addiction treatment programs had waitlists measured in weeks, with no prioritization for people with active xylazine wounds despite their medical urgency. Detoxification facilities could manage opioid withdrawal, but had no protocols for the prolonged dysphoria of xylazine withdrawal. Residential rehabilitation programs required medical clearance that actively infected or necrotic wounds didn't meet, creating catch-22 situations where people needed to heal their wounds before entering treatment, but couldn't heal without stopping drug use that required treatment to quit. Technological approaches to harm reduction showed promise without achieving scale. Smartphone apps connected users with real-time drug checking results, allowing people to verify what they were buying before using it. Wearable devices similar to fitness trackers monitored vital signs and could alert emergency services if heart rate or oxygen saturation dropped to dangerous levels. Needle exchange programs distributed fentanyl test strips and now xylazine test strips, empowering users with information about drug contents. These innovations were valuable, but reached tiny fractions of the user population and couldn't overcome fundamental problems of contaminated supply and insufficient treatment access. The current state of the xylazine crisis in late 2024 and early 2025 was one of grim equilibrium. The drug was thoroughly entrenched in North American opioid supplies with no prospect of elimination. Medical and harm reduction systems had adapted to provide the best care possible within severe resource constraints. Government agencies had implemented nominal responses that satisfied political requirements for action without substantially reducing harm. Thousands of people continued developing wounds, experiencing overdoses and dying each year. The veterinary sedative that nobody wanted in their drugs had become standard, and society had adjusted to accepting the casualties as the price of failing to address root causes of addiction or drug market structures that incentivized dangerous adulteration. The zombie drug had won, and America had learned to live with the corpses.